building, and it's nice to see how far in time it goes. So that's
I
incredible.
worked there in 1993. So that time
Yeah.
it was quite out of, the maintenance. But now it has become very nice.
I think almost everyone has worked in Shroff. I think most of the Delhi doctors.
I haven't worked. You offer me a job, then maybe I should come and work with you for a while.
Yeah, sure. Our pleasure. But Dr. Harsh knows how hectic it is. He keeps telling me.
We are
Job
like,
at Shroff is very hectic.
Okay.
Okay, we are live now.
Yeah,
So,
sure.
Dr. Ajay, you want me to start?
yeah, please.
Hello.
Yeah, please start.
Okay. A warm welcome to all the participants. And this is our third clinical meeting of the Noida Ophthalmological Society. And it includes a symposium on the glaucoma management, both from medical and the surgical side. And with the stalwarts like Dr. Sunita, Dr. Harsh, and Dr. Reena Chaudhary, I'm sure we are going to learn a lot from their experience and expertise. And I really thank Dr. Reena and Dr. Ajay, who have been tirelessly working on for this symposium. And now I'd like Dr. Ajay to take over and introduce the speakers and start the proceedings.
Thanks, Dr. Atul. So this is our third monthly clinical meeting, and this is live on YouTube and Facebook. We're very fortunate to have Dr. Harsh Kumar, who is a very good friend. He is the director of glaucoma services of the Center for Sight. Earlier, he was professor of ophthalmology at RP Center. He's got an extensive experience over the years. I think Harsh's name is enough for the introduction. If I start introducing Harsh and Sunita and Reena, I think this program will be over. So I'll restrict my introduction. Thank you, Dr. Harsh, for being here. Dr. Sunita, thanks for being here. Sunita is well recognized all over the country as a leading expert in glaucoma, and I'm happy that we have worked together. I was in Shroff for many years when actually Shroff started, and we were together, and those were great memories. So welcome Sunita. She is the director of glaucoma service at Shroff Eye Hospital, Bariaganj. And Dr. Reena, she's the NOS faculty. Everybody knows Reena Chaudhary. She's the medical superintendent of Eye Care Hospital, director of glaucoma services of Eye Care Hospital, doing excellent work. So thanks, Reena, for putting this entire symposium in order, and you will be moderating the session. So I think Dr. Rajat and Dr. Aarti would probably be joining us. Let's hope. And Reena, please take over. Thank you.
Good evening, everyone. And as Dr. Ajay put it, we are looking forward to people benefiting from the talks Dr. Sunita and Dr. Harsh have put together. And we have some interesting cases. So it'll be nice to discuss and learn from each other. So without wasting time, may I request Dr. Sunita, you to start. She'll be talking on the diagnosis and management of glaucoma. So we can just start straight away from her and then take question and answer. People can put questions in the chat box if they have any questions, and we can take them at the end of the session.
Okay, so I'm sharing my screen. So thank you, Dr. Reena and Dr. Ajay and NOS for inviting me. And I'll be talking on diagnosis and management. So basically, I'll be talking on diagnosis because the management part will be covered by Dr. Harsh. So as we know, India contributes to 1/5 of the global burden of glaucoma. Approximately 12 million people are affected by the disease, and we have equal proportion of open and closed angle glaucomas as opposed to the Western countries where the open angle glaucoma is more common. However, there is an urban and rural disparity, and there is much more prevalence in urban India as compared to the rural. And as we know that India currently has an expanding aging population with greater life expectancy. So we expect a lot more patients with glaucoma. So we are very familiar with this diagram. And if you look at the natural history of glaucoma, it goes from a disease of undetectable disease to asymptomatic disease, and then the stage of functional impairment. And untreated glaucoma may cause blindness in 3 to 15 years, depending on the level of intraocular pressure and rate of progression. And lack of awareness about glaucoma is a very important reason for late presentation and risk of blindness. Evidence suggests that the structural loss precedes functional loss. And in the landmark study, ocular hypertension treatment study, disc changes were detected much earlier than the visual field abnormality in more than 50% of the patients. So the detection of early glaucomatous damage is the key for early treatment. Clinical evaluation of optic nerve head and RNFL remain the gold standard and most important for the diagnosis of glaucoma, especially the early glaucoma, despite so much of technological advances. So it's very important to draw a very good diagram, but now we have EMR, so it may not be possible to draw a very good diagram of the disc. So you have to write each and every finding of the disc or take stereo photograph of the disc. So careful examination of the disc parameters is very, very important. And there are a myriad of parameters which are there, but one needs to keep these 5 R's and for the disc assessment, which are very important. The scleral ring to identify the size of the optic disc. I'm going to go in details about each of them. Identify the size of the neuroretinal rim, retinal nerve fiber layer, parapapillary atrophy, and retinal and optic disc hemorrhages. So first and foremost, it's very important to determine the size of the optic disc and which is the inner edge of the scleral ring. So as you can see here, this appears as a whitish halo if it is present 360 degree, or as a crescent if it is present less than 360 degree. Inclusion of this scleral ring into the optic disc area markedly enlarges the area of NRR. As you can see, this is the actual margin of the disc, and this is the margin of the cup. And around that is the scleral ring. So if you include the scleral ring into the disc area, your disc area becomes too large, and erroneously it will measure the neuroretinal rim as thick. So this is very, very important. We do a stereoscopic evaluation of the optic disc with the help of one of these lenses. And it's important to measure the size of the disc, and we do it with the reticule. And don't forget to multiply it with the corrective factor, which is different for different lenses. Since we use, in most of our cases, 90D lens, so it is multiplied by 1.33. So this gives you the diameter of the disc, so or size of the disc. There is a lot of variability in the shapes of the disc, and it is not uncommon to see variable shapes. And the longest axis of the disc may not be vertical always. As you can see here, it may be torted, like if it is more than 15 degrees deviated from vertical meridian, it is said to be torted. Sometimes it is just 180 degrees torted. And then tilted optic disc, which is very commonly seen in patients with myopia. So basically, tilt is produced because of the oblique entry of the disc. As you can see here, this is both the nasal and the temporal aspect of the disc are on the same plane. But in case of tilted disc, the nasal aspect is slightly anterior and the temporal aspect is posterior. So basically, it's the angulation of the antero-posterior axis of the disc. We are very, very used to measure the cup disc ratio because it is quite user friendly. However, one has to keep the size of the disc in mind while evaluating the CD ratio. And as you can see, you have to differentiate the cup margin from the neuroretinal rim. And the best way to do is to follow the optic nerve blood vessels, as you can see here, as they travel into the floor and then climb the wall of the cup. So here is the second kink, which is very important and which determines the cup margin. So you have to do a stereoscopic disc evaluation to find out the depth of the cup. Neuroretinal rim, as I said, a very important parameter, and its identification in all sectors is of fundamental importance. And we are all aware of the isn't rule, which means the inferior and neuroretinal rim is thickest, followed by superior and the nasal and temporal. So loss of neuroretinal rim is the cardinal feature of glaucomatous neuropathy. And the rim loss also occurs in a sequence. It occurs in the inferior-temporal region, then superior, then temporal, and then nasal, and it is because of the crowding of the fibers at the inferior pole. Color of the rim is important, as NRR pallor is not very typical of glaucoma, and NRR seems to be pink in most of the glaucoma patients, and a mismatch between pallor and NRR can be early sign of glaucoma. Otherwise, pale disc signifies non-glaucomatous optic neuropathy. It's very important to do a dilated evaluation, to do a clinical evaluation of RNFL, and it is best performed using red-free light, or you can use green light in your slit lamp or in red-free photographs. So you have to look for the striations, and as you can see in a young normal individual, you see these bright striations, but when there is RNFL defect, you see these wedge-shaped defects. These are the localized defects, and they fan out from the disc. Parapapillary atrophy, alpha and beta zone, and beta zone is more characteristic of glaucoma, and it is at the edge of the disc. Disc hemorrhage, again, is very specific for glaucoma, as it is not found in normal individuals, and they signify progression. So whenever you see a patient with a disc hemorrhage, you have to follow up the patient, and during follow-up visit, you can see thinning of the neuroretinal rim at the site where disc hemorrhage was there. So they signify progression, and this is one of my patients who had very advanced glaucoma in one eye, and the other eye had very early glaucoma. As you can see here, there was hardly any visual field defect in the left eye, but in the coming follow-up, the patient developed this disc hemorrhage and high pressure, and although the treatment was stepped up, but within 4 months he progressed very fast, because the patient was from out of station and didn't visit for 3 to 4 months, and the pressures were high. So disc hemorrhage, I think you need to follow these patients very stringently, and disc hemorrhage is the predictor of progression. OCT has revolutionized the diagnosis and monitoring of glaucoma, and we often now include OCT in our diagnostic armamentarium, and it is more objective and quantitative, and you can evaluate RNFL, macula, and optic nerve head changes at the same time with very high reproducibility and reliability. And now we have spectral domain and swept source OCT, which have much better resolution and faster scanning speeds. So, and OCT has been very useful in diagnosis of pre-perimetric glaucoma. As you can see in this picture, in the early stages of the disease, there is a fast deterioration of RNFL, and the visual field remains stable for quite some time. And then there is fast deterioration of visual field. So it may be important to diagnose the disease in the early stages. And you can see here, you can diagnose it with the help of OCT, and which correlates well in most of the cases with the disc findings, where you can see the fundus findings, where you can see these RNFL defects clinically also. However, one should be aware of the artifacts which are not uncommon to see in an OCT, especially if it is not performed properly. Poor centration, as you can see, this broken pores of the blood vessels, and this will produce the motion artifacts. And when you repeat the OCT, you can get an absolutely normal OCT. Similarly, you must be aware of the green disease and the red disease. So green disease, when there's thick myelinated nerve fibers here, which obstruct the acquisition of the image around the optic nerve, can produce the green disease, because it can hide the glaucomatous loss in glaucoma. And similarly, the VR traction. So as you can see here, this traction of the vitreous can lead to artificially thick RNFL. So in such cases, the macular RNFL, macular or ganglion cell imaging is better. We also know that OCT is not very useful in very advanced cases because of the floor effect, because when the RNFL thickness reaches about 40 to 50 microns, it bottoms out because of the presence of other supportive tissues like glial tissues and astrocytes. So there's no point in doing OCT or following up the patient with very advanced cases with OCT. And of course, in high myopia, it produces red disease because of the large disc and peripapillary atrophy. So visual fields are useful. However, I would emphasize here one point that OCT is quite useful and good diagnostic strategy to rule out glaucoma in patients who have not been able to perform visual fields properly because of the learning curve. As you can see in this patient, a lot of learning defects are there. And if there's no artifact and if the disc is also, within normal range, then the OCT, if it comes out to be normal, you can rule out glaucoma. However, one has to correlate disc and field changes. So aware of the red and green disease, and clinical decisions should never be driven by OCT results alone. A good clinical evaluation and field is must. So the visual field function is still the gold standard in the diagnosis and management of glaucoma. And the glaucomatous progression is almost 10 times faster than the normal rate of decay of visual function with age. So there is some decay with the age also, as you can see in this diagram. But if the rate of progression is very fast, then it can lead to blindness if the disease is not treated aggressively. So the best way to manage glaucoma is to determine the rate at which the disease is changing. It's very, very important. And just one or two examples of my patients here. You can see this patient has been following up with me since 2003. So in 17, 18 years, this patient has hardly progressed. And this line is almost straight. And this is a slow progression. So you don't require that much of aggressive treatment, as opposed to this patient where you see this line is pretty steep and this patient progressed very fast and the rate of 16.7%. So you need very strict follow-up and very aggressive treatment in such type of patients. It's always better to establish a valid progression. I think this is one of the most important step in managing patient with glaucoma. And increasing frequency of visual field testing helps to detect progression faster. And consensus is that you perform 6 visual fields in first 2 years. And why it is important to perform 6 fields in first 2 years? Because you can detect progression faster. If there's progression of -2 decibel per year, then you can detect it in 1.5 years if you're performing 3 tests. But it may take you to detect it in 3.3 years if you just perform 1 test per year. So it's important to perform more tests in 1 year. I will not take much time here because Dr. Harsh is going to talk about it. But in newly diagnosed patients, since there is no rate of progression, you need to consider the risk factors like family history, pseudoexfoliation, and other systemic disease. And IOP, I think, is the most important treatable factor. And I have seen in most of my patients in 25 years of career that the patient progresses very fast if the IOP is not maintained. In low pressure glaucomas, they do not progress fast. Their progression is very slow. So in my opinion, IOP is the most important factor, and it has to be considered in patients with ocular hypertension and POAG. The risk factors, as I talked about, are very, very important, and you just treat ocular hypertensives and POAG suspects if they have risk factors, not otherwise. So to conclude, a detailed clinical evaluation is a must, and we perform optic nerve head evaluation, dilated evaluation of optic nerve head and visual fields, and OCT also in most of our cases now. It's important to assess the rate of progression and identify rapid progresses. And not all perimetric glaucomas and ocular hypertension treatment patients require treatment, you need to consider risk factors. And last but not the least is proper communication of the patient is crucial to improve compliance and prevent progression of the disease. Thank you very much.
Thank you so much, Dr. Sunita. That was, of course, a very, very elaborate and brilliant presentation on diagnosis. And I think, as rightly mentioned, that red and green disease should be highlighted on the OCT. And OCT is a great tool, but must be used with intelligence and clinical correlation. And fields still remain our main investigation to go to, because it's the functional loss that we are trying to prevent from getting worse to maintain good quality of life. So, and also I think Dr. Aarti has joined. So welcome, Dr. Aarti. I think you'll have to unmute yourself. Yeah, hi.
Hi, hi.
So
And
Dr.
Dr. Anupama has also joined. Welcome.
Yeah, hi, Dr. Anupama. Dr. Aarti and Dr. Anupama both are very renowned ophthalmologists in Noida, practicing glaucoma as well as anterior segment, and Dr. Anupama also does some retina. So we have some case discussions at the end of the day also to discuss. And is there anything anybody would like to comment on, Dr. Harsh, Dr. Aarti, Dr. Prerna, Upasna? Anybody would like to comment on diagnosis talk that we've had?
Why don't we go on? Anupa, you have to unmute.
Yeah. Thank you so much for introducing, and I would say it's a wonderful job taken up, and Dr. Ajay, hats off to Dr. Ajay, Dr. Reena for organizing such a wonderful meet.
Thank you.
So there are no questions on the chat box. Should we proceed with Dr. Harsh?
Yeah, I think, let's finish up the presentation.
So I think I'll request Dr. Harsh to please start talking on the medical management. He'll be talking about the fewer medications possible. I think he calls his talk as, let me read it, start early, lower the better, fewer the better. So sir, or please.
ठीक है भाई, आ गया क्या?
हाँ जी.
आगे सर, आगे.
दिख रहा है, गुड. चलो भाई, बहुत बहुत धन्यवाद अजय, रीना एंड अतुल, and it is nice to be here with you guys. Have been fond memories of Noida Ophthalmic Society, but of that nice hall and beautiful hotels. But anyway, अब जो है उसमें काम चलाया जाए. तो ऑलरेडी सुनीता ने, आवाज साफ है भैया?
बिल्कुल साफ है.
चलिए, तो सुनीता ने पहले ही बहुत बढ़िया तरीके से एक एक चीज़ बता दी है कि भाई रेड डिजीज़ को देख के ग्लॉकोमा मत बना दो, उसको अच्छे से डायग्नोज करो, और सिर्फ डिस्क को ही अच्छे से देख लिया जाए तो बहुत हद तक उसको पकड़ा जा सकता है. तो पहली चीज़ ये देखनी पड़ेगी भाई ग्लॉकोमा है कि नहीं, है तो किस तरह का है, क्योंकि 30-40% काला हमारे एंगल क्लोजर है जिनका ट्रीटमेंट ही फ़र्क तरह से हो जाएगा. किसको मैं देख रहा हूँ, सबसे ये बहुत ज़रूरी बात है. स्पेशली दिस टॉक इज़ टुवर्ड्स द यंगस्टर्स, जो हम लोग उम्र वाले लोग हैं, अजय और ये लोग, इनको सब कुछ ऑलरेडी आता है, उनको बताने की कोई ज़रूरत नहीं है. प्लीज़ स्पेंड 5 मिनट्स विद अ पेशेंट हु इज़ न्यूली डायग्नोज्ड ग्लॉकोमा. हिंदुस्तानी आदमी का फ़ायदा ये है कि उसके साथ 10 मिनट तुम बैठ जाओ तो उसकी सारी लाइफ की कहानी तुम्हें पता लग जाती है. सो सम पीपल हु आर लुकिंग वेरी वेरी elite at the moment you talk to them and क्या चल रहा है अभी सिन्हा साहब, अरे सर कुछ नहीं, वो जॉब चली गई, अब कुछ बचा नहीं है, बड़ी मुश्किल से काम चलता है. And you suddenly realize that possibly in this case, instead of giving a prostaglandin analog, I can do with a beta blocker. So these are things that you have to know about the patient, कि भाई कितने पैसे वो कमा रहा है, उसकी कितनी और प्रॉब्लम्स हैं. उसके बाद जब ग्लॉकोमा तुम डायग्नोज कर चुके हो, टारगेट प्रेशर क्या रखना है, किस मेडिसिन से शुरू करूँ भाई, और पेशेंट कंट्रोल्ड है कि नहीं, ये हमने पता कर लिया है कि नहीं. और सबसे ज़रूरी चीज़ जो बहुत सारे यंगस्टर्स और हम में से भी शायद कई लोग अपने बिजी क्लिनिक्स में भूल जाते हैं कि पेशेंट तुम्हारे पास दवाई लेने नहीं आया है, ही इज़ कम टू बी हील्ड. सो प्लीज़ उसके साथ बैठो, उसको ये बताओ कि यार तुम अगर रेगुलरली मेरे पास आते रहोगे, हर 2-3 महीने में एक बार प्रेशर करवाते रहोगे, हर 6-8-10 महीने में हम एक फील्ड कर लेंगे, तो मेरा तुमसे प्रॉमिस है कि तुम कभी भी ब्लाइंड नहीं होगे. ये सेंटेंस बोलना उनको ज़रूरी है. आई हैव सीन पीपल हु हैव कमिटेड सुइसाइड आफ्टर रीडिंग ऑन नेट दैट दे आर गोइंग टू गो ब्लाइंड बाय ग्लॉकोमा. सो प्लीज़ ये काम करना बहुत बहुत ज़रूरी है. जैसे सुनीता ने बताया भाई, आजकल अगर डिस्क में NRR हेल्दी नहीं है, यहाँ पे एक रिम डिफेक्ट है, और सिमेट्रिकली यू हैव गॉट अ फील्ड डिफेक्ट, देन यू नो इट इज़ ग्लॉकोमा. बट ज़रूरी नहीं है, क्योंकि आजकल प्रेशर उसमें उसके डायग्नोसिस में भी नहीं है. पर बहुत और चीज़ें हैं जो ज़रूरी हैं. एक बहुत इंपॉर्टेंट बात है कि डायगनल वेरिएशन करना बहुत ज़रूरी है हमें. और अगर डायगनल वेरिएशन बहुत लार्ज है तो फिर अगेन इट इज़ नॉट ओनली द प्रेशर बट ऑल्सो द डायगनल वेरिएशन विच इज़ इम्पॉर्टेंट. और कई लोग कहते हैं सर ये 4-5 बार प्रेशर कौन करेगा, हमारे बस की नहीं है, किस में करना है ये बता दो, स्पेशली व्हेन आई गो टू स्मॉलर सिटीज़. तो भाई अगर नॉर्मल टेंशन ग्लॉकोमा है, तुमने डायगनल वेरिएशन किया और देखा कि कोई प्रेशर उसका एक्चुअली में ज़्यादा आ रहा है, तो तुम्हारे बहुत सारे इन्वेस्टिगेशंस बच गए. वरना तुम उसका MRI कराते, डॉपलर कराते, वैस्कुलर हार्ट का सारा चेकअप कराते, वो सब बच गया. अब सपोज ऑकुलर हाइपरटेंशन है उसको, भाई उसका डिस्क बिल्कुल ठीक है, फील्ड बिल्कुल ठीक है, पर प्रेशर उसके ऊपर जा रहे हैं. तो वहाँ ये जानना बहुत ज़रूरी है कि क्या प्रेशर किसी भी समय 28-29 टच कर रहा है. क्योंकि अगर वो टच कर रहा है तो irrespective of everything else we will have to start treatment even in that normal disc and field. ये बात जानना ज़रूरी है. उस समय हमें डायगनल वेरिएशन करना पड़ेगा. या तुमने अपने मन में एक टारगेट प्रेशर सेट किया, वो सेट कर दिया, तुम्हारे ऑफिस आवर्स में बंदा आया और उसका प्रेशर बिल्कुल ठीक है, पर वो फिर भी उसका फील्ड खिसकता जा रहा है, भाई क्या करें. तब यहाँ पे करके देखो कहीं ऐसा तो नहीं है कि किसी और टाइम पे उसका प्रेशर बढ़ रहा हो जो हम पकड़ ना पाए. और पहले हम लोग क्या करते थे कि भाई एडमिट कर दिया उसको और फटाफट उसके एक ही दिन के अंदर 4-5 प्रेशर कर दिए, और अगर पॉसिबल हुआ तो रात में कर दिए. पर अब वो देखा गया है कि बेटर ये है कि उसको अपनी नॉर्मल ज़िंदगी जीने दो. किसी दिन 9 बजे कर दिया, एक और दिन बुलाया 12 बजे कर दिया, फिर 3 बजे कर दिया, 5 बजे कर दिया, ऐसे ऐसे अलग टाइम पे जिससे उसकी ज़िंदगी चल रही है. ही इज़ इन द नॉर्मल रन ऑफ थिंग्स एंड येट यू आर डूइंग वेरिएशन एट वेरियस टाइम्स व्हिच विल गिव यू द करेक्ट रीडिंग्स मोस्ट ऑफ द टाइम. सो सिर्फ प्रेशर को नीचे नहीं रखना है, प्रेशर को हर समय नीचे रखना है एक रेंज के अंदर. तो भाई सुनीता ने डायग्नोज तो कर दिया, आप कितना नीचे रखें उसको. हम बहुत सारे फॉर्मूले हैं इधर उधर, पर मोटा मोटा बात यह है कि इफ़ द डिस्क एंड फील्ड आर आइदर नॉर्मल जैसे ऑकुलर हाइपरटेंशन में है या बहुत माइल्ड डैमेज है, देन वी आर फाइन विद गेटिंग द प्रेशर बिलो 21. बट अगर मॉडरेट डैमेज है या वन आइड पेशेंट है या रिस्क फैक्टर्स बहुत ज़्यादा हैं, तो भाई 14-15 के आसपास रखो. और अगर बहुत सीवियर फील्ड लॉस है, एडवांस डैमेज है, वन आइड पेशेंट है, तो प्रेफरेबल ये रहेगा कि भाई 8 से 12 के बीच में रखो उसको. तो ये हमने पहली सोच है हमारी कि भाई इसको यहाँ तक रखेंगे. तो वो एक बार ऑफिस में आया तो आ गया भाई उसका 8 से 12 के बीच में. पर तुम्हें उसका एक डायगनल कंट्रोल करके देखना है कि क्या सारे टाइम पे ऐसे ही रह रहा है इसका प्रेशर. और फिर 3-4-5 महीने बाद हमने, अगर बहुत एडवांस फील्ड है तो 3 महीने बाद, अगर बहुत नॉर्मल टाइप की फील्ड है तो मे बी 6-8 महीने बाद एक फील्ड दोबारा किया. अगर फील्ड ठीक है तो मेरा मतलब है कि भाई ठीक है, हमने अपना जो सोचा था डिसीजन वो सही है. पर अगर फील्ड फिर नीचे खिसक रहा है, इसका मतलब है अगर मैंने 12 सोचा था तो 12 नहीं भाई, इसको 10 रखो या 8 रखो इस प्रेशर. तो डायगनल तो टारगेट प्रेशर एक मूविंग चीज़ है. और मेडिसिन स्टार्ट करने से पहले सुनीता ने शॉर्ट में दिखाया, पर बहुत बेहतरीन दिखाया कि मैक्सिमम प्रेशर लोडिंग होना चाहिए. एक मेडिसिन का मिनिमम नंबर ऑफ टाइम्स डालनी चाहिए. वो मेडिसिन अगर 24 आवर्स इफेक्टिव है तो बहुत बढ़िया भैया, क्योंकि एक ही बार डाली काम अपना चल गया. और कोल्ड चेन ना उसमें रिक्वायर्ड हो तो बहुत बेहतर है, क्योंकि हिंदुस्तान में वो काम ज़रा मुश्किल ही है. और डायगनल वेरिएशन को ब्लंट करें, ये भी बात याद रखना ज़रूरी है. साइड इफ़ेक्ट्स मिनिमम हो, नहीं तो मरीज़ डालेगा नहीं. कॉस्ट भी देखना ज़रूरी है. और बेहतर ये रहेगा कि अगर वो आउटफ्लो इंक्रीज़ कर रहा है, क्योंकि दोज ड्रग्स आर ऑलवेज बेटर. और जैसे उन्होंने बताया था पहले ही कि कॉर्नियल थिकनेस अगर कम है मरीज़ की, अगर एक बहुत ज़रूरी बात है फैमिली हिस्ट्री. मैं तो कई बार क्या बोलता हूँ भाई मरीज़ को कि यार अपने, वो कहता है जी मदर को ग्लॉकोमा था, क्या हुआ था यार याद नहीं, पता नहीं, दवाई क्या चल रही है याद नहीं. तो यार व्हाट्सएप है ना, उसका एक सबसे बड़ा फ़ायदा है कि भैया बाहर जाओ, पहले व्हाट्सएप करवाओ, दिखाओ मुझे उनकी फील्ड कैसी है और क्या हाल है. सो इफ़ दैट पेशेंट, इफ़ दैट मदर हैज़ ऑलरेडी बिकम ब्लाइंड और द फील्ड्स आर एडवांस डैमेज, यू विल बी वेरी एग्रेसिव. पर अगर तुम्हें देख रहे हो अरे ऑकुलर हाइपरटेंशन है यार, एक आध दवाई चल रही है इसकी, तो कोई टेंशन नहीं. तो फैमिली हिस्ट्री एक बहुत ही इम्पोर्टेंट चीज़ है. कोनियोस्कोपी हमने बताया ही आपको, क्योंकि ज़रूरी इसलिए क्योंकि अगर वो एंगल क्लोजर ग्लॉकोमा है तो चांसेस ऑफ डैमेज आर मच हायर. एंड 3 बार उसके मतलब द डैमेज कैन बी ऑलमोस्ट, द ब्लाइंडनेस कैन बी 3 times. सो यू हैव टू बी वेरी वेरी केयरफुल. और ध्यान रखिएगा कि अगर एक आँख उसकी 3-4 दवाइयों पे कंट्रोल है, मरीज नहीं भी चाहता, आप भी नहीं चाहते, पर प्लीज़ क्रॉनिक एंगल क्लोजर में ट्राई करिए कि एक आंख को तो एटलीस्ट ऑपरेट कर ही दिया जाए, जिससे दे विल डू वेल इन अ लॉन्ग टर्म बेसिस। पिगमेंट डिस्पर्सन है, स्यूडो एक्सफोलिएशन है, तब भी आपको थोड़ा ज़्यादा केयरफुल रहना पड़ेगा। और फर्स्ट लाइन ऑफ थेरेपी जैसे मैंने समझाया भाई, ऑलवेज वी विल लाइक टू गिव अ पीजी एनालॉग, क्योंकि उससे अच्छी कोई चीज़ नहीं है। पर देन इफ द पेशेंट कैन नॉट अफोर्ड, तो 30-40 रुपए की भैया बीटा ब्लॉकर भी बहुत बुरी नहीं है, सालों से हिंदुस्तान का उसी ने फायदा किया है। देन कम्स के सेकेंड लाइन हमारी क्या होगी, सपोज हम ये दोनों नहीं दे पा रहे, तो यू कैन आइदर एड डोर्जोलोमाइड, बेंजोलोमाइड और ब्राइमोनाडिन, और इवन अ कॉम्बिनेशन ऑफ दीज टू विच कैन एक्चुअली हेल्प। और अगर ये सब नहीं हो पा रहा है तो याद रखना भाई, पाइलोकार्पिन भी एक बेहतर दवा है, और आजकल नई दवाइयाँ आई हैं जैसे नेटारसुडिल है, रॉटर्स है, एंड ट्रैब इज ऑलवेज एन ऑप्शन फॉर अस। एक बहुत अजीब बात मैंने देखी है कि अगर 20-30 का प्रेशर होता है, लोग एकदम टूट के उसको, चल भाई इसको ये पीजीआर लॉक भी दे दो, ये भी दे दो, वो भी दे दो, डायमॉक्स भी दे दो। अरे भाई टेंशन मत लो यार, ओपन एंगल ग्लॉकोमा है, उसका डिस्क उसका मोटा मोटा ठीक ही है, थोड़ा बहुत मॉडरेट डैमेज है, तो कुछ नहीं होने जा रहा है उसको, ये सालों से चल रही है इसको बीमारी, आज तुमने पकड़ ली तो अलग बात है। तो पहले एक दवाई शुरू करो एंड सी कि कितना उससे लोअरिंग होता है। अगर 15 से 20% से ज़्यादा लोअरिंग हो रहा है, दैट मीन्स दैट ड्रग इज़ इफेक्टिव। उससे कम हो रहा है तो भैया तो दवाई का वो चेंज करो। अगर वो एक ब्रांड है तो दूसरा ब्रांड कर सकते हो, या उसी में ब्रांड में 2-4 चीज़ें हैं तो उसको चेंज करो, और उसके बाद ही कुछ उसको एडिशन करो। फर्स्ट चेंज, स्विच एंड देन ऐड। हाँ, अगर IOP 30 से ऊपर है, देन आई विल अलाउ यू टू फर्स्ट हैंड ऑल्सो स्टार्ट अ कॉम्बिनेशन। कॉम्बिनेशन स्टार्ट करने की दिक्कत ये है कि अगर उसको साइड इफेक्ट हुआ तो अपने को पता नहीं भाई किस चीज़ से साइड इफेक्ट हुआ था, सो तब भी कई बार इफ़ यू कैन अफोर्ड इट इज़ बेटर टू गिव 1 बाय 1। पर अगर 40 से ज़्यादा प्रेशर है, देन आपको साथ में एस्टाजोलामाइड वगैरह देना पड़ेगा, क्योंकि 40 से ऊपर ड्रॉप अंदर पेनेट्रेट ही नहीं करेगी। तो पहले उसको ये दे के उसको लोअर करो, और फिर साथ में उनको दवाइयाँ शुरू करिए आप। और ऐड जैसे हमने कहा था, अगर पीजीआर लोग हैं तो डेफिनेटली टेमोलॉग के साथ बेस्ट एडिशन है, क्योंकि एक ही उसको ड्रॉप डालनी पड़ेगी। पर अगर वो काम नहीं कर रही है, देन यू कैन डिसाइड कि वेदर यू वांट टू ऐड डोर्जोलामाइड, बेंजोलामाइड, या आप ऐड करना चाहते हो ब्राइमोनाडिन को, या और नई दवाइयाँ आई हैं क्या आप उनको ऐड करना चाहते हो, या पाइलोकार्पिन कर सकते हो। और एंगल क्लोजर का बता ही दिया था मैंने। जब दवाइयाँ हम लोग डालते हैं तो ऑब्वियसली बीटा ब्लॉकर्स जब हम देते हैं तो हम सिर्फ एक चीज़ पूछते हैं कि भाई उसको सांस में प्रॉब्लम तो नहीं है, हार्ट में ब्लॉक तो नहीं है। पर करेंटली व्हाट इज हैपनिंग इज अ लॉट ऑफ पीपल आर वेरी वेरी अवेयर, and I'm surprised and I'm proud that a lot of people are accepting that yes, they are having depression, and so many young people come and say yaar sir ye kya dawai de di, hamara to sexual life has become totally bad. So you have to think of all these things which are modern day diseases and modern day obsessions and modern day normalities. So your drug should not affect that, and please, क्योंकि इसमें CAD का रिस्क बढ़ जाता है, क्योंकि लिपिड प्रोफाइल ऑल्टर हो जाती है बीटा ब्लॉकर्स से, तो प्लीज़ उनको पंक्चुअल अक्लूजन सिखाइए। आज भी मैं बताना चाहूँगा कि कितने ही लोग मेरे पास कहीं और से लेके आते हैं पर्चे, तो उसमें नहीं बताया गया है भाई मरीज को कि पंक्चुअल अक्लूजन करो। वेरी फ्यू पीपल स्टिल टेक द टाइम, सो प्लीज़ टेक 5 मिनट्स, सिट विद द पेशेंट। एंड डॉक्टर रामाकृष्ण टॉट मी दैट द ब्यूटिफुल थिंग इज कि पहली बार उसको अपने हाथ से दवाई डालना सिखाओ, तो पता लगेगा किस तरह से वो दवाई डाल रहा है, कैसे उसको पंक्चुअल अक्लूजन करना है, एक ही बूंद अंदर जानी चाहिए। ऑल दीज थिंग्स आर स्मॉल बट दे गो अ लॉन्ग लॉन्ग वे। जब बच्चों को बीटा ब्लॉकर दे रहे हैं तो पंक्चुअल अक्लूजन बहुत ज़रूरी है, क्योंकि इवन स्मॉलेस्ट ड्रॉप कैन कॉज एरिथमियाज एंड कॉज एस्थमा, जिस उनको समझ में भी नहीं आएगा। ब्राइमोनाडिन अ वंडरफुल ड्रग जिसकी प्रेशर लोअरिंग पीजीआर लॉक के बाद सेकेंड लोअरेस्ट इसी से होता है। And we know that somewhere or the other there is a neuroprotective element as well involved. प्रॉब्लम क्या होती है कि कई लोगों को नींद बहुत आती है, कई लोगों को बहुत ज़्यादा एलर्जीज हो जाती हैं, तो उसके बारे में उन्हें पहले से थोड़ा सा बता देना चाहिए। बच्चों में बिल्कुल नहीं यूज़ करनी है, लेस देन 6 years प्लीज़ डोंट यूज़ इट। And dorzolamide, brinzolamide, excellent drugs given in TDS dosage. They have effect in the night also. They supposed to increase ocular blood flow also. बट बी वेरी केयरफुल, कोई भी प्रकार का कॉर्नियल डिकम्पोजिशन है तो इसको मत यूज़ करिए। एस्टेरजोलोमाइड देने के टाइम बहुत ध्यान रखिए कि अगर ओल्ड पेशेंट है तो प्लीज़ उनका LFT KFT रेगुलरली कराते रहो। इलेक्ट्रोलाइट इम्बैलेंस हो गया, पता लगता है दिया तो तुमने डायमॉक्स था, मरीज एडमिट हो गया, किस लिए हुआ है पता नहीं, बट एक्चुअली ही हैज़ गॉट दिस इलेक्ट्रोलाइटीमिया। मैनिटॉल देने से पहले बहुत केयरफुल रहो। अगर सिंगल प्रैक्टिस में है तो प्लीज़ देख लो आसपास कोई हॉस्पिटल। आई हैव सीन पेशेंट्स गोइंग टू कंजेस्टिव हार्ट फेलियर इन फ्रंट ऑफ मी, so be very careful. PG analogs, definitely beautiful medicines, alternative pathway, they lower the pressure below the episcleral venous pressure. Single dose होती है और lowering even 10 millimeters I have seen so many times. और एक बहुत इंपॉर्टेंट सवाल जो हर समय पूछा जाता है हर मीटिंग में, तो मैं पहले ही बता दूं कि भाई सर कौन सी यूज़ करनी है। सो अब डेफिनेटली आई विल नॉट टेक ब्रांड नेम्स, बट येस, definitely bimatoprost would give you the greatest lowering, and 0.03% bimatoprost was the finest drug as far as the lowering was concerned, but obviously hyperemia was too much, so they converted it into 0.01 जिससे hyperemia बिल्कुल ही गायब हो गया है, but lowering is pretty much the same, though maybe a shade less. Travoprost may give you almost same, maybe just a shade less, but definitely latanoprost has lesser lowering than both these drugs. एंड बट द एडवांटेज ऑफ लेटानोप्रोस्ट कि कोई फसी पेशेंट है जो बिल्कुल भी हाइप्रीमिया नहीं चाहता, देन यू आर ऑन द सेफर ग्राउंड ओवर देयर। बट लेटानोप्रोस्ट में येस, दे आर नाउ ब्रांड्स विच डू नॉट रिक्वायर अ टेम्परेचर रेगुलेशन, बट बाई एंड लार्ज अगर टेम्परेचर रेगुलेशन रिक्वायर्ड है तो इंडिया में उसके लिए थोड़ी प्रॉब्लम ही है। बट PG analogs आर द ड्रग ऑफ चॉइस। येस, बी केयरफुल, टेल देम कि भाई जब भी डालो तो स्किन पे उसको ना जाने दो, क्योंकि उसी से पिगमेंटेशन डेवलप होती है। एंड दे कीप वॉचिंग फॉर पिगमेंटेशन, जल्दी पकड़ लेंगे उसको, रिवर्स कर देंगे तो वो दोबारा ठीक हो जाएगी। लैशेज एलोंगेट हो जाते हैं तो कभी यूनिलैटरल केस में प्लीज़ मत यूज़ करिए। देयर कुड बी स्मॉल अदर थिंग्स लाइक ऑर्बिटल फैट एट्रोफी, कीप अ ट्रैक ऑफ दैट। रोप्रेसा इज अनदर ड्रग विच आई वाज यूजिंग इवन बिफोर इट वाज इंट्रोड्यूस्ड इन इंडिया, क्योंकि हम जो 3-4 यहाँ लोग बैठे हैं पैनल में, उनके सबके पास ऐसे मरीज आते हैं जो ऑलरेडी 3-4-5 दवाइयों पे चल रहे हैं, तो एक कुछ भी एडिशनल दवाई मिल जाए तो हमारे लिए बहुत अच्छा है। दीज रो काइनेस इनहिबिटर्स आर गॉड सेंट फॉर अस, बिकॉज जो भी दवाई चल रही है उससे ऊपर हम ये ऐड कर सकते हैं। एंड फ़ायदा इनका ये होता है कि इससे एपिस्क्लेरल वीनस प्रेशर भी कम होता है। प्राइमरी एक्शन ये है कि ये आउटफ्लो को बढ़ाते हैं, बट नेट इनहिबिशन की वजह से एक्वोस्यूमर प्रोडक्शन भी लो होता है। So they are wonderful drugs. So we have Ropresa and we have Ripasudil. Both are now available in India. Problem क्या होती है कि subconjunctival hemorrhages are known और मरीज हमेशा चिल्लाता है सर ये तो लाल हो गई आँख, बट जो जिनको हम दे रहे होते हैं उनकी ऑलरेडी आँख लाल है क्योंकि 4 दवाइयाँ चल रही होती हैं। तो गिव इट एज अ सेकेंड ड्रग इज अ लिटिल डिफिकल्ट बिकॉज इट इज़ अ वैसोडाइलेटर, हाइपरीमिया होगा ही होगा, पर अगर तुम्हें देना ज़रूरी है तो मरीज को पहले समझा दो एंड थिंग्स यूजली वर्क आउट वेल एंड द प्रेशर लोअरिंग इज प्रीटी गुड। प्रेगनेंसी में हमेशा याद रखना प्लीज़, कौन प्रेग्नेंट होगा तुम्हें नहीं पता है। 18 साल से ऊपर जो भी लड़की आए प्लीज़ उसके, मैं कितने बच्चे बच्चियां देख चुका हूँ जिनको किसी ने नहीं बताया, ड्रग्स उनकी चल रही हैं। सो प्लीज़ राइट ऑन टॉप, बी सेफ लीगली कि इफ़ यू कंसीव प्लीज़ स्टॉप ऑल एंटी ग्लाइकोमा मेडिकेशन एंड कम बैक टू अस। So please be very careful. Brimonidine is the only drug which can be safely given. But if it doesn't work, you can do ALT, SLT. अगर वो भी उससे काम ना बने तो कभी कभी ऑपरेट करना पड़ता है। तो एंड प्लीज़ याद रखना कि ब्राइमोनिडीन दे तो दी है, पर जब वो ऑलरेडी शी इज़ गोइंग टू डिलीवर, यू हैव टू स्टॉप द ड्रग एटलीस्ट 15-20 days in advance, नहीं तो she may feed the baby and the drug may go into the baby and cause irreversible damage. Astazolamide, कई बार मैंने देखा लोग अरे घबरा के जल्दी से चलो यार 2 गोलियां 4 बार दे दो, 500 ग्राम QID ये सब भर दिया, पर भाई साहब कोई फायदा नहीं होता। The maximum tolerance, the dose which really works is 250 milligram QID, so be careful about that. बट लॉन्ग टर्म में जो एक चीज़ ने मेरी प्रैक्टिस को थोड़ा सा चेंज किया है, आई रियलाइज दैट पीपल आर गिविंग फॉर ईयर्स एंड ईयर लो डोज डायमॉक्स फॉर अदर थिंग्स। सो व्हाट आई हैव डन नाउ इज कि वो पेशेंट जो सर्जरी नहीं कराना चाहते, सारी मेडिकेशंस पे बड़े मार्जिनली कंट्रोल्ड है। वी एक्चुअली वांट अ स्लाइटली बेटर कंट्रोल, दे डोंट वांट सर्जरी, यू डोंट वांट टू डू सर्जरी। 1 नाइट पेशेंट है, 5 डिग्री फील्ड बची हुई है, उनमें अगर लो डोज हाफ टैबलेट एस्टाजोलामाइड BD-TDS चला दो, LFT KFT देखते रहो, तो बहुत फायदा होता है पेशेंट को, बिकॉज ही कैन एस्केप सर्जरी एंड ही कैन बी गुड फॉर अ लॉन्ग टाइम. अगर क्लियर नहीं है कि किस वजह से फील्ड्स नीचे जा रही है, प्लीज उनका 24 आवर बीपी कराओ और देखो कि कोई बीपी, उनका डायस्टोलिक बीपी 70 से नीचे तो नहीं जा रहा है. अदरवाइज दीज आर हाइपरटेंसिव पेशेंट, टेल टॉक टू देयर कार्डियोलॉजिस्ट कि भाई इनका बीपी इतना नीचे मत जाने दो. बहुत सारे लोग सुबह उठ के वाटर ड्रिंकिंग टेस्ट कर रहे होते हैं, अपना 4-4 लीटर पानी पी के. उनको समझाओ कि भाई नहीं पीना है एक साथ इतना पानी, इफ यू हैव गॉट ग्लॉकोमा. And asanas, most of the yogic asanas can stop breath, increase the pressure. So please tell them not to do that. Instead, do a lot of walking and meditation. And be careful that they don't have sleep apnea. So we have already decided the first line of therapy will be PG analogs. If the patient cannot afford, then beta blockers and pilocarpine can also work. If those don't work, then dorzolamide, brinzolamide along with brimonidine or a combination may work definitely. But always remember, you are surgeons. And हर बहुत clearly ये बात बताई गई है कि surgery actually on a long term basis can control the pressures better than any combination of medication. So please tell them what is glaucoma. Take out 5 minutes of your time. टेल देम कि शेड्यूल क्या है फॉलोअप का. बहुत लोगों को नहीं पता. पंक्टल अक्लूजन 90% लोगों को नहीं बताया जाता. एंड प्लीज टेल देम दैट इफ दे कम रेगुलरली दे विल बी गुड फॉर लाइफ. थैंक यू वेरी मच.
Thank you so much, Dr. Harsh. As always, it's a pleasure to hear you. You give such good tips on the medical management of glaucoma patients. For the people who are attending the meeting, if you have any questions, please put it in the chat box so that we can ask the presenters these questions for you. And I think, sir, you rightly mentioned some very important points like mentioning punctal occlusion, which I'll be honest, sometimes we all tend to miss in a busy practice. And I think it can't be overemphasized that the small things really matter a lot on a long run. So we have to pay attention. And medical management is, and again, कहते हैं ना कला है, as you rightly said. So you have to look at the patient in totality. And please don't be in a rush to add multiple drugs, as sir has reminded all of us, that we must go slow, especially in an open angle primary disease. If you're dealing with secondary glaucoma, sudden increase in IOP, 50, 60, then of course giving multiple drugs together can make sense. All the other people on the panel, would you like to add something, ask anything? Okay, so Dr. Ritu has asked a question, Dr. Harsh. Would you use rho kinase inhibitors as the first line therapy?
So like I already told that there's a lot of hyperemia in these patients. And the lowering is not as good as that of a PG analog. So definitely not as a first line, not even as a second line. We usually add it up later.
Right, right.
So in my experience, I think there are two types, riparsudil and nitarsudil. Riparsudil has lesser hyperemia as compared to nitarsudil. Nitarsudil, I think Nitalo, which is available as Nitalo, almost every patient has hyperemia. I don't know what is your experience, but so I'm not very comfortable using Nitalo.
Yeah, so
yeah,
like we said, we are using only when, because I, Sunita and Reena are always getting patients who are already on 4 medications.
Yeah.
We don't want to do surgery sometimes, then we'll add on this drug and they are happy, we are happy. So then they really don't bother about the hyperemia.
Yeah, we don't use it as first line at all as of now. 1 or 2 patients initially we did offer, but somehow we felt that it wasn't easily accepted by them compared to the PG analogs. So as of now, I think as you're rightly saying, it's another drug in the kitty which you often need, but not as a first line, not as yet.
I'd like to ask Dr. Harsh and Dr. Sunita, what are the maximum number of drugs you would put a patient on before you would contemplate surgery? Because we have so many drugs available now, and oftentimes you see a patient who's on 6 eye drops. Medications become very difficult for the patient also to manage. So what is the maximum number which you would,
you keep on adding till they are so tired that they'll say, please, ab surgery kar.
But Harsh, what is the definition of a maximal glaucoma therapy, anti-glaucoma?
Yeah,
You
see,
have to have a definition.
by definition, you see, for each patient, things are different. But let me tell you, okay. So if I start off, let us say I've given a PG analog, then I've added on a combination of brimonidine, timolol. Then I have given dorzolamide, brinzolamide 3 times a day. Okay. Then sometimes we add on pilocarpine to this, and then we add on ripasudil to this BD. Okay, so I have some patients who are not ready for surgery and are well controlled on this amount of medication. And like I told you, that sometimes even half tablet Dimox BD on addition to this may be tolerable to a lot of patients. Not that we are wanting to do it, but the patient is simply refusing surgery, and one has to control the pressure under any circumstances. We tell them, moment I touch 3 medications, I tell them, yaar, ab surgery kabhi na kabhi karni padegi, tum apna man banao. But till they are not ready, you
I
can't.
think now the best part is now we have most of the medications available as combination. So what sometimes I do is that I give a combination of PG analog and timolol, Ganford or Travacom, and then brinzolamide and brimonidine. So these are 4 salts and just 3 drops. And then you add, as Dr. Harsh said, either ripasudil or maybe pilocarpine. And so I think that way I have also started adding Dimox, because especially in children, I think children tolerate Dimox very well, children with secondary glaucomas. But in adults, if they don't have any disease, severe hypertension or kidney disease and all, then they can also tolerate. But one thing I want to emphasize here is that if you decide to do surgery on a patient who has been on maximum medical therapy for a few years, I think it is always good to prime the conjunctiva with steroids, because all these drugs as preservatives cause a lot of inflammation, and surgery is going to fail invariably if you just operate in this inflamed conjunctiva. So I think now I try to give steroids under Dimox, of course, because you can't just, once you have decided about the date of surgery, say a week or 10 days later, you can just start the steroids a week before.
So
That is what I have started doing.
What steroids will you start and for how long?
Pred-acetate, I think. Pred-acetate is good enough, but one needs to be very sure that the patient's date of surgery is fixed, because it will cause a lot of improvement in the ocular surface. And if the patient is not getting operated, then he may continue using steroids, which can cause a high IOP. So one has to be very, very careful and explain to the patient. I feel nowadays patients are also quite intelligent to understand everything, what you're explaining to them.
No, I think there's a sweet spot you have to find, because the more you keep treating them with topical drugs, as you said, the more the tab failure also eventually.
Yeah.
When you know a patient is progressive, and by putting 3 to 4 drops a day, he's not coming under control, the threshold to advise surgery and to do surgery earlier is better, because your success of trabeculectomy is also going to be better when the conjunctiva is not a tomato red and the patients are using multiple drugs. But of course, there are subset of patients who are either not keen for surgery, or you have other vulnerable situations that you can't offer surgery. Then of course one has to go and extend as many possible medical drugs that we can use in those patients, provided they can tolerate it and that's not contraindicated. But otherwise, if you have 4 drugs in 2 bottles, 3 drops, or maximum 4 drops a day, we often tend to advise them surgery.
So Reena, one thing we have to, we are actually taking for general ophthalmology. It's fine for me, you and Sunita to do these surgeries. But a lot of general ophthalmologists actually are not comfortable doing a trabeculectomy. So I would request them that in a situation like this, instead of delaying it, because we all are getting patients which are far delayed. So please take heart. Even if you refer to any of the people nearby who are actually doing regular traps, the patient will not be unhappy. He will come back to you only. But please do refer in time.
Right, Ji. There is another question, sir. It says that in young patient, steroid responder glaucoma, should we go ahead with PG analog? Sir, would you like to take this?
Yeah, why not? There's no harm in that at all.
So you can absolutely go ahead and treat them with PG analogs.
Reena, can you?
Yeah.
Reena, I think we will be running short of time. So why don't you finish your presentation, and we'll have other.
So I am just sharing my screen.
While Reena does this, let me thank Allergan for supporting the symposium. And Allergan have been very kind. They have supported the symposium, and we have a lot of drugs in their booty, and Allergan drugs are very dependable. We all use them regularly. Thank you.
Okay, so I think in my talk, basically, I have made my talk more surgical short videos to give some tips on the surgical success of trabeculectomy. So the theoretical part, when to do and all that might be a little limited here. And we still know that trabeculectomy remains the gold standard, although there are a lot of newer glaucoma surgeries that everybody's talking about. Then there are tubes and all, but trab still tests the test of time. So, and also we know the trabeculectomy, if done well and if successful, can give us really good lowering of IOP, which can be well maintained and reduces the fluctuations, which is again something that is often required for patients who have advanced glaucoma. So, and we know how it works. The basic principle is that partial thickness filtration procedure, and where you're trying to have the aqueous filter from the anterior chamber into the subconjunctival space. And the goal is to just get the right amount of flow without causing overfiltration. And the success relies not only on the patency of the fistula that you're creating, but also the ability of the filtering bleb to continue to absorb aqueous. And the maximum amount of failure happens because of subconjunctival scarring. And I will quickly show you, of course, as to what is usually done to try and prevent it as far as possible. And the success also depends on the surgical technique, intraoperative and postoperative measures to modulate the wound healing in such eyes. Of course, it's very important to educate the patient and to have realistic expectations from surgery. Besides the consent, it's also important to actually have a good look at the patient to understand if there are any risk factors for filtration. If the patient already has scarring of the conjunctiva or the limbal anatomy is stretched, like in a child and all, where you can face challenges. If there's already inflammation in the eye, which is again a risk factor for failure. Ocular surface disease due to the multiple drugs, as Dr. Sunita was mentioning, sometimes might need steroids before you take them up for surgery. Any previous surgery also makes the success of surgery go down a little. So one has to keep that in mind and also plan the surgery accordingly. Plan whether you're going to use mitomycin C, in what concentration, for how much duration, depending upon the severity or the risk factors for failure. The suturing techniques, whether you will plan to do releasables or sutures that can be lysed with laser, these are things you have to keep in mind. Very high risk for complications on the table like nanophthalmus, uncontrolled pressures. You might even think of replacing sutures or keeping a sodium hyaluronate kind of viscoelastic on a standby to avoid fluctuations on the table. And I'll show you in the videos shortly. Always stop the blood thinners and anticoagulants wherever possible before the surgery, because if you bleed under the conjunctiva, the scarring can get even more enhanced. And also you don't want these patients to bleed with the block also. And I like to do my trabeculectomies under block, although it is possible to do under topical as well. Always give mannitol before surgery, if not contraindicated. Measuring pressure on the day of surgery is, I mean, you can do it if it gives you peace of mind, but very often we don't do it if we are giving mannitol and we know that the patient was at what range before we planned the surgery. Preoperative antibiotics and betadine is something you're all familiar with. But what do you do with the anti-glaucoma medications, especially PG analogs? Should we withdraw them or should we continue it till the day of surgery? Now that all depends on how the conjunctiva is looking. If the conjunctiva is very inflamed and you can see the ocular surface disorder is significant, maybe there is some wisdom in trying and stopping one or two drugs which you think are the culprit for 5 to 7 days before surgery. Give them Diamox cover and give them a mild steroid for 4 or 5 days before surgery. But remember, as Sunita said, that the surgery must be fixed and the patient must be under your care. I do all my surgeries under peribulbar block and retrobulbar block. I think most of us don't give it anymore. Subtenon's anesthesia is a possibility, but please do not give too much mechanical pressure after giving the block in these eyes. And also topical is a possibility, plus minus sedation, depending upon the patient profile. You need to use a superior bridal suture or corneal traction suture to try and expose the superior area for the surgery. But nowadays what I do is I use this speculum, which you can see is different for right and left eye, which actually helps you expose the superior part conjunctiva very well without having to take that bridal suture. So if you look at this, this is the standard speculum, which opens the eye like this. And in the same eye now, I am using the other speculum where the lower arm is much longer. And you will see that it pushes the inferior fornix this the speculum goes and sits in the inferior fornix, pushes it in a way that you have the superior part exposed very well. So I think I've moved on using this speculum, and I thus avoid the use of the sutures in most of my patients. Now, conjunctiva is something that you have to respect the most when you're doing trabeculectomy, because as I said, that it is the conjunctiva, subconjunctival scarring that causes failure in most patients. So please be very delicate, and you want to assess the how good the conjunctiva is, because if the conjunctiva is very thin and you had planned to use mitomycin C in the concentration of 0.4%, you might even want to change it to less. So conjunctival health is important, and you can choose to make either fornix based or limbal based flaps. We all have moved towards the fornix based flaps nowadays, because we know that it allows us to make our filters move more posteriorly and avoid the possibility of creating small blebs which are overhanging on the cornea. So I think most of us, the glaucoma surgeons, are moving away from doing limbal flaps, limbal based flaps. They're also slightly difficult to do and can have a chances of buttonhole, but it's easier to close. But you'll end up sometimes getting these very small localized blebs because of the scarring that develops at the level where you made the cut, making the ring of steel. So now the modified Moorfields technique tells us to make a fornix-based flap, as I just showed you, and do a wide application of mitomycin C so that you can get a diffuse, larger bleb. Now here I want to highlight that you do want to modulate your wound. Mostly we use antimetabolites, mitomycin C, and I've soaked my sponges in mitomycin C, and it's important to make sure that you count the sponges you're putting. And I will just pause here and look at this. You have to hold the conjunctival edge and keep it away from those soaked sponges, because you don't want the edge to touch the mitomycin C, but you want a nice wide area to get the mitomycin C contact, because you want your blebs to be diffuse and not small localized and be filtering posteriorly. And you use it for 1 minute or 2 minutes, depending upon how severe the disease is and how much lowering are you wanting to plan to get. And the concentration, I like to play around with 0.02 to 0.4 milligram per ml. And to make it, I think you can theoretically just check how to make this solution, but please discard it very well. And after you waited for the time, remove it in the same order that you had put it in. Discard it very safely, because this is a hazardous drug. And thereafter, meticulously wash your conjunctiva with at least 10 to 20 milliliters of saline, making sure that no residue of mitomycin C is floating around on the surface. And those instruments also, I like to move away and use a fresh set of instruments. Creating a scleral flap now can be either rectangular or triangular. That is okay, both work well, but more and more we like to use a rectangular flap. And the important thing is to maintain a same plane when you're dissecting. And also don't over cauterize the sclera, because when you over cauterize the sclera, it lands up shrinking. So as you can see over here, just gently try and maintain the same plane. And the other important thing to remember is that the flap tends to now stop short of the limbus. The anterior part of the dissection you'll see now, I'm going to use a crescent, because I don't want the flap edges to go and touch the clear cornea. So this is all that I dissect and leave it about 1 millimeter behind the limbus, and then use a crescent to go in till the clear cornea. So the anterior part of the flap has the sides closed. Only the sides are open at the posterior part. This allows posteriorly filtering blebs which are not overhanging and which are large and diffuse. So if you see this picture also, we've done the anterior dissection here, but the flap is actually stopping a millimeter or so behind the limbus. And understanding the anatomical limbus, surgical limbus, is extremely important to be able to make the right ostium. Paracentesis is extremely critical, and you want to do it at this stage when the eye is still firm, and you're going to only gradually decompress the eye when you actually enter it through the scleral flap. And also this side port is going to come handy when you're trying to check filtration or reform the anterior chamber during the surgery. Having done that, you go and enter your scleral flap with a keratome, but make sure that the entry is where you had extended the dissection into the clear cornea. Then you want to do your sclerostomy either using the Kelly sponge, or you can use your blade and scissor. But the important thing is that you want to eat away that your blue zone. That's where you remember the surgical anatomy, where white meets the blue. That's where your Schlemm's canal is, and you're basically trying to create this ostium in the blue zone to make sure that you've dissected the trabecular meshwork out, and then do a peripheral iridotomy. The peripheral iridectomy should be of ideal size. It should be not too big so that the patient doesn't have a problem of diplopia, but it should not be too small either so that it doesn't block your ostium. And you make a small iridectomy and don't try to meddle too much over there and play around with it with the instruments. And make sure that the ostium does have a decent amount of scleral tissue remaining on the sides so that overfiltration risk is reduced significantly. So you make sure that the ostium is created in a way that you do not let the ostium touch almost the edge of the scleral flap. Sometimes in patients where you're worried that on the table there is a risk of, let's say, pressures going up, of choroidal effusions and all, suprachoroidal hemorrhage where the pressures are very high, then make sure that in such patients you can either use pre-placed sutures, and I'll just show you how to do that. Look at this patient. This is a nanophthalmic eye. The PI has already been done. And what I'm doing is, after creating the flap, I'm putting pre-placed sutures so that in case there is any challenge during surgery, I can quickly close my flap. So I'm going to just take these 2 bites and leave it alone. And then I'm going to enter the scleral flap with my keratome or the blade and scissor. Here I'm choosing to make my ostium with a side port blade and scissors. Either way it works. And in some cases I used Helon in the eye, just very little, not too much to overflate the eye, but enough to not cause enough chamber fluctuation. And Helon is very easy to get out of the eye. You don't have to do an IA to do that. If you just inject the fluid and decompress it, it pops out because it is a cohesive viscoelastic. So in high risk cases, do not shy away from taking enough measures on the table also to reduce the chances of any complication. Now in the closure, I think a closure of a trabeculectomy flap is extremely, extremely vital because in the post-operative period, it can give you a chance and a opportunity to titrate your pressures if you have to. So I like to put my rectangular flap closure by placing 2 sutures which are non-releasable, but then I also put 2 releasable sutures which allow me a good flexibility, and in case I need to remove them in the post-operative period to lower the pressure, I have that possibility. And I can still laser suturalize these fixed sutures. So if you see, I took a bite in the clear cornea, then I made a little loop on the cornea here and went in, and then throw a loop and take 3 turns on the suture, and here's your releasable. You can pull it from the end and see that it works well, and nicely tighten it and check the amount of filtration that you're getting over there. This end of the suture, I want the eye to be not too soft, not too hard, and just a little ooze once you have finished your suturing. You inject a little bit of saline from the side and see that your end result should be a little bit of ooze. You don't want a very tight or a very soft eye. Thereafter, having done the releasable sutures, the conjunctiva closure has to be very meticulous because we are doing now fornix-based flaps, and leakages from this conjunctival edge can be common, especially if the mitomycin C touched it and if you've not closed well. So what I like to do is do a purse string, like a running suture, and try and buckle it towards the edge. Rather than taking just a wing suture, I take the suture into the limbus, come back and take 1 or 2 sutures into the conjunctiva and just crowd it into that corner so that the conjunctiva is nicely sealed. I have given up on using vicryl sutures, although they dissolve and you don't have to remove it, but they cause a lot of inflammation and you'll end up getting a lot of vascularizations on the bleb, which eventually tends to fail your blebs. So over the years now, I like to use steno and I remove it. I know it causes my patient an extra, sometimes visit to the OT to remove it if it's a challenge doing it on the slit lamp in some cases, but mostly the slit lamp is fine. Having done the 2 wing sutures, I like to put a mattress suture in the middle where I do a nice bite onto the peripheral clear cornea and then go through the conjunctiva and push it down onto the peripheral cornea, sealing it watertight. And that is extremely, extremely beneficial. So you see, I'm taking 2 nice mattress sutures and making sure that my edge of the conjunctiva is going to be watertight at the end of the surgery. As you'll see, I'm going to inject some saline from the side. I'm burying these not inside the clear cornea so that the irritation is a little less. Now you'll see that nice bleb is going to come up with my injection, but if you'll touch the conjunctival edge, it's nice and dry. No aqueous is leaking out. This is what we'd like to see at the end of the surgery. Ologen is the newer product available, which can also help you modulate the wound. If you're using Ologen, please do not use mitomycin C because it's a substitute for mitomycin C, not to be used in combination. Because of the lack of time, I'm just telling you how it is used. You must use releasable in Ologen because suturolysis will be very difficult through Ologen. And at the end of your suturing, my oozing has to be a little more ologenized because there is a tamponade effect with the ologen. So now you can see I put 2 releasable and there is a good ooze. I'm putting the ologen over it, and my suturing is still going to be as meticulous because I don't want this ologen bleb to try and protrude out from any side. So I'm still quite meticulous, although mitomycin C is not being used, so the risk of leakage is a little less, but I don't want the edge of the ologen to show out from the conjunctival edge. So I line up suturing these wounds also watertight, and see how the bleb is rising and the ologen is sitting under the conjunctiva. This is what the ologen blebs look like post-operatively, and slowly over time, the ologen starts to get absorbed, and you have a very shallow bleb, but they function fairly well. This is the airosity of an ologen bleb. You can see the disc is sitting over here, and you can see there's a significant amount of filtration happening subconjunctivally. And I think post-operative regime is familiar to all of us, and post-operative management of these patients are what makes the glaucoma surgery a success. You like to keep them on cycloplegics for a while, maybe 2 or 3 weeks also if required, steroids at least 2 to 3 months in tapering dosage, and please don't hesitate in taking applanation tonometry in every visit. Look for wound leaks and bleb vascularity, and modulate the management in case you want to release the sutures or suturalize the suture with laser. You must not hesitate if required. This is what we want the blebs to look like in the post-operative period, but unfortunately in some eyes it's not the same. Now let's look at this patient. Very often doctors ask me, what do you do with releasables? When do you release it? You can see over here, I'm pulling out a releasable suture on the slit lamp under a drop of paracaine. It's very simple to pull it out with a forceps, a sterile forceps, and very often the bleb starts to come up. And if you want to trim it, if the pressures are good, all you have to do is grab it. Your attendant can lift the lid, use a scissor, press it down onto the cornea, and just cut the suture. The remaining bit will just snap back into the cornea and will not irritate the patient at all. So these sutures can be very easily managed in the post-operative period. Sometimes you have these blebs which land up becoming vascular and very shallow, and they're actually going towards failure. Teaching a bleb massage can be extremely helpful. And first, you need to establish when massage can help this patient or not. So as you can see on the slit lamp, I'm trying to put a little pressure over the bleb area to see actually if my bleb starts to increase a little bit. And the vascularization in this patient is quite a bit. He's actually going towards failure. And I'll show you in the next slide that I actually decided to give him a mitomycin C injection in the OPD in the subconjunctival area. So as you can see, very little change in the bleb is happening over here. Some amount of filtration is showing up in this picture. And can you see the difference from before and after the massage? And in this patient thereafter, I am going to give a very small 0.1 ml of 0.2 milligram per ml concentration mitomycin C on the slit lamp, and then wash the eye well with the normal saline. These patients take it very well under topical anesthesia. And after making this nice small blister, what I do is I use my finger onto the lid and massage it towards the bleb. So this also reduces the bleb vascularity and teach the patient how to do massage at home. Sometimes you're able to salvage these blebs if detected in time. So you'll see I'm going to give some massage onto the lid to try and spread this mitomycin C towards the bleb site. You can have wound leakages and overfiltering blebs, which is again a very, very long talk to cover. But what is important is look for leaks and shallow ACs and manage. Do not hesitate to take sterile applanation tonometry in every patient of trabeculectomy that you've operated in the post-operative period. And sorry about the sound. This is a wound leak patient, and very often wound leaks settle down with patching and all. But as you see in this patient, there is a nice buttonhole along the suture track, which wouldn't seal down no matter what we are doing. And I had to take him back into the OR to try and suture this small buttonhole. And what I've done is I'm doing a purse string suture under topical anesthesia under the operating microscope. Just take a suture into the peripheral cornea, and then go around this little buttonhole and try and just wrinkle this around this conjunctiva around this buttonhole and just put it back so that your leakage will stop immediately and the patient can be just left alone. You don't even need to patch them thereafter. So you can see that I'm taking the suture just around that buttonhole, and once I tighten it, that part of conjunctiva is just going to come together and make this stop this leakage. So here this suture, can you see this crowding of the conjunctiva, and that buttonhole has stopped. See, the conjunctiva is all dry now. So you can see also post-operatively, the leakage has stopped and the bleb is starting to form well. So overfiltering blebs again are not unusual, and usually they settle down very often spontaneously. You can patch these eyes. You can also sometimes put them in aqueous suppressants. Lesser fluid formation will also reduce the overfiltration. Cycloplegia can also help them. And very rarely, when things are not working, you might need to put compression sutures. You can see this patient has a very large bleb and shallow AC, which just wouldn't settle down with patching, and even AC deformation didn't help. And what we went and did over here is we put a large compression suture at the edge of the scleral flap. What I'm doing here is I'm pressing with the buds to identify where my scleral edge is, and once I can see it after I press the conjunctiva, I'm going to take a large, deep suture over this area and tighten it down so that the overfiltration through that edge is taken care of. And later on, this suture can be removed once the scarring sets in. So you can see that I'm taking a very deep bite going through the scleral thickness, and I'm going to come back and tighten it down and compress that edge of the scleral flap, which is filtering a lot. And they do very well. You can, sometimes you might want to give a small block in these patients, because if you're taking a deep suture, they can have pain and you want them to be stable. So as you can see that I put a very tight suture over the scleral edge, and the overfiltration will give the same patient. You can see the suture over here, and the AC is now well formed. So needling, unfortunately, I couldn't find a video to show it to you, but encapsulated blebs respond beautifully to needling with a small amount of mitomycin C injection also on the table, and needling is quite easy to do with a 26 gauge needle. I do it nowadays under topical anesthesia. It's easier for my patients to look down and just do topical anesthesia, and you're able to needle them, or you can even inject a very little amount of oculant subconjunctivally. So ideally, we want the blebs to look like this in our postoperative period. This is very early post-op, and this is almost a year later. You can see it's a diffuse bleb, very little vascularity, but it's not avascular, it's not too red. And these are the blebs which will be successful in a long run. So everything that you can do on the table and on the post-operative period to be meticulous can help you in a long way to achieve very good results in your TRAP patients. So thank you.
What a wonderful presentation, Reena.
Thank you. Sorry, I think I took some...
Fabulous, you know. When a retina surgeon can appreciate this, it means
so you can only
general ophthalmologist.
You can only appreciate, but we can use it. I'm so happy.
I liked every bit of it. Wonderful videos, practical slit lamp videos.
Absolutely fantastic.
Very nice.
Thank you.
I have a question. Yeah, I have a question. You know, I think before we go further, I want to ask a question to Harsh, because we're actually also running short of time. Harsh, there's a question which has come up, is that, you know, there are combinations available these days of timolol with latanoprost, timolol with travoprost, timolol with bimetoprost. Now, how do people select which one to use? Do you have anything scientific data which can show?
I'll just show you something that I've got in 1 second. So can you see this?
Yeah, we can see it. Yeah.
Okay, so there was this study and published in Eye. So they actually looked at latanoprost-timo combination with a bimeto-timo combination. And what they ultimately found was that bimeto-timo was definitely far superior to latano-timo. That I already told you, that there's no doubt about it, that bimeto will give you the further lowering, and timo is just an addition to both of them. But yeah, it does work well. And if you see with Travo and timolol and take the same thing, again, what it is showing is that definitely you'll get a much better lowering with bimetoprost combinations. So that we had already described that bimetoprost would probably give you the lowest whenever you are aiming for a lower pressure. This is what you are likely to get.
Right, thank you.
Dr. Reena, I would like to ask you a question. While you are doing the conjunctival dissection, I have seen a few surgeons, they dissect the tenons also. Subtenon dissection they do, and while they're reattaching the conjunctiva, they reattach the tenons also. So is it worthwhile, or we should leave behind the tenons?
So it's a very good question. The tenon has to be dissected, because if you leave the tenon behind, getting a nice clearer flap will not work and your surgery will also fail. So the tenons definitely needs to be dissected. We'll end up usually getting a plane, which is subtenons. But
Right.
also in patients, who are using a lot of anti-glaucoma medications and they're not young patients, usually the tenons is not a problem. Tenons becomes a problem when you're dealing with young patients where there's a very thick tenons. Normally, when you dissect the conjunctiva, the tenons is dissected along with it. And also when you're suturing, as you saw in my technique, very
Right.
often the suturing happens together. But in some young patients, you'll find that the tenons is extremely thick and care should be taken that you don't land up leaving behind the tenon flap hanging free. That also will cause either an encysted bleb or a failed bleb. So if the tenons was very thick, then make sure that when you're suturing the conjunctiva, you actually go through the tenon's bite and then the conjunctiva, so that when it gets pulled towards the limbus, the tenon is also pulled along. You can separately suture it, but that usually only is required when you're doing limbal-based flaps. When you do a conjunctiva, fornix-based flap, normally you don't have to do it because you've dissected in a way that the conjunctival addition to the limbus is more anterior to the tenons, right? So it's very easy to try and take a suture bite through both the layers together.
I think for the case discussion, we may be running short. We have only 4 cases. Each case will be for about 10 minutes with a 6-minute presentation and 4 to 5 minutes discussion. So if there are no more questions for Reena, Dr. Jawaharlal Goel, who is the chairperson, and is Saurabh joining Reena?
I think he should be. I'm sitting in a different room.
I called him, but he did not. But anyway, you have to moderate the session. So I'll request Dr. Professor Goel to take over, and I will request Dr. Harsh and Sunita to stay back, because these case discussions, everybody would like your opinion on these cases. I really appreciate that. Thank you. Yes, sir, you have to unmute yourself. Dr. Goel, you have to unmute, sir.
Okay. Thank you, Dr. Ajay. And now I welcome Dr. Harsh and Dr. Sunita Dubey, who are the panelists for this session. And moderator is Dr. Reena Chaudhary. So she will be moderating the session. We have 4 speakers, Dr. Rita Hansaria, Dr. Anupama Upasani, Dr. Prerna, and Dr. Ritu and Dr. Ajay Roda. So I hope everyone will be enjoying the case presentations. Now, first I will request Dr. Reena Chaudhary to introduce Dr. Rita Hansaria for presentation of the case. Dr. Reena.
Yes, so Dr. Rita is here with us. She's a senior glaucoma consultant at Eye Hospital. So, and she's been working in glaucoma for the last now, I think 10, 11 years. So over to you, Dr. Rita, for your case presentation. Unmute yourself, Rita.
Dr. Rita, unmute, please.
Yeah, a very good evening to everybody. Thank you, Dr. Reena and NOS, for giving me this opportunity. I'll just share my screen. Is the presentation visible?
Yeah.
Yeah.
So today I discuss a case of a 32-year-old female who presented first in July of 2019 with the complaints of frontal headache, pain and redness on and off in the right eye for the last 2 to 3 months. There was no history of any diabetes, hypertension, any cardiac illness, no family history of glaucoma was given. On examination, the BCVA in the right eye was 6.6 N6 with a minus 0.75 cylinder. In the left eye, it was 0.25 cylinder. Cornea was almost clear with a few pigments in the right eye endothelium. Anterior chamber noted was very, very shallow. In the right eye, it was almost flat inferiorly, and there was a broad pass extending from 4 to 8 o'clock, and a small pass was also visible at 2 o'clock in the right eye. The left eye had appositional, was almost von Erich's grade 1 with a very shallow AC. Iris pattern in the right eye was atrophic, and the pupil was inferonasally indrawn. Applanation tonometry measured in the right eye was 28. In the left eye, it was 14 millimeters of mercury. When we did the gonioscopy, the PTM was visible only in 2 quadrants in the right eye, with the pars visible, and the left eye was appositional closure in all the quadrants, opening up to scleral spur or indentation. The fundus was 0.3 cup-disc ratio in the right eye and 0.2 in the left eye. A provisional diagnosis of iridocorneal endothelial syndrome with an underlying PACS in the right eye was made, and the left eye PACS. The investigations, specular microscopy, showed a few endothelial changes in the right eye. The left eye was pretty normal. The corneal thickness was 550 microns in both the eyes. The Humphreys visual field in the right eye showed a few scattered scotomas superiorly. The left eye Humphreys was normal. OCT, RNFL, and GCC was more or less normal with a few inferior thinning, mild thinning changes in the right eye. The anterior segment OCT depicted the pars, which was visible in the cornea. And the UVM was also done to exclude any push mechanism. Diagnosis of iridocorneal endothelial syndrome in the right eye and left eye, PACS, was made. The patient was started on timolol maleate, 0.5% twice daily in the right eye, and was asked to follow up. After 3 weeks, the IOP recorded was 24, a left eye YAC-PI was done, and another drug was added in the right eye, a combination of brimonidine and timolol. Patient next followed up with a pressure of about right eye 22 millimeters of mercury. The left eye was doing fine, but on examination, 1 clock hour pars seemed to have been increasing in the right eye. The CDR ratio in the right eye seemed to have increased to 0.5 with inferior rim equal to superior rim. A close follow-up was advised and the patient was continued on the combination therapy. Here a Humphreys was also done, which was still normal. The patient next came after about 2 months when the pars was seen to have increased and the IOP was now on 34 millimeters of mercury in the right eye on the combination therapy, and the fundus showed a CDR which has increased to 0.65, although the inferior rim was little or equal to the superior rim. Dorzolamide eye drops were added thrice daily in the right eye, and the patient was counseled for an early surgical intervention in the right eye. The left eye with a patent PI was stable on an IOP of 16 millimeters of mercury. Patient next came after a month or so. The pressures were still high borderline and need of early surgery was re-emphasized. Meanwhile, the patient has visited elsewhere for a second opinion where pilocarpine eye drops was added in the right eye. The pandemic happened and the patient was lost to follow-up. When she next came to us in November 2020, there was a significant increase almost of about 280 degrees in the right eye, extending from 2 to 11 clock hours. The cup-disc ratio was 0.65 with significant IR thinning. IOP measured by applanation was 51 millimeters. Post-mannitol, it came down to 34 and the patient was on 3 anti-glaucoma medications. Acetazolamide tablets thrice daily was started. Humphreys was again done, and this time it showed a early supranasal defect in the right eye. The Humphreys left eye was normal. Patient was advised right eye trabeculectomy with MMC. Patient underwent the trabeculectomy elsewhere with MMC in the right eye, and she visited us again for a follow-up in the first week of December, where her visual acuity was 6.6 with a sphere of plus 0.5. There was a good bleb, limbal based with 2 releasable sutures, and the IOP was 14 millimeters of mercury. Patient was using atropine thrice daily and was a tapering dose of Tedfort. Subsequent follow-up, we regularly followed up the patient, and after about 2 weeks, we stopped the atropine eye drops in the right eye. She was doing well. After about 4 weeks, the patient again came to the OPD with a complaint of blurring of vision in the right eye. Visual acuity noted was 618, and she improved to 6/6 with a minus 1.75 sphere and a 0.5 cylinder in the right eye. There was a good bleb with no leak. The AC was shallow. The pars was 2 to 11 o'clock. IOP was well maintained at 10 millimeters mercury. Fundus was saying there were no evidence of any choroidals. An impression of an iris lens diaphragm shifting anteriorly was made. So UBM was done and the atropine eye drops was restarted, to which the patient responded very well. Her BCVA improved to 6.6 with a minus 0.75 cylinder. Patient was continued on atropine thrice daily and an impression of aqueous misdirection was done. A UBM and ASOCT was also done to confirm the findings. The patient was followed up after 2 months, and an attempt was then again made to stop the atropine eye drops, whereupon a myopic shift was again visible. So the patient was advised to continue with atropine thrice daily. The IOP was now well maintained, and she was on topical steroids. So the challenge is, the patient is a young patient with a good IOP control post-surgery. Attempt on reducing the atropine is causing a myopic shift definitely. So what should be the further approach? The case is now open for discussion.
Thank you, Dr. Rita. Also, I think in this case, because I also happened to see this patient, very typical signs of ice were present on the iris when we first saw her. The challenge in this patient was very shallow ACs in both the eyes. The lens is quite thick and the chambers were shallow throughout, but very typical signs of aqueous misdirection started to show on stopping atropine at 3 weeks. So Dr. Harsh, Dr. Sunita, will be very happy for you all to discuss this patient further.
Yeah, actually, eye syndrome, I think it's very, very challenging situation, and we get to see a lot of patients with eye syndrome. And since it's a progressive condition, like it's a pathology of corneal endothelium, so over a period of time, this endothelium grows over the trabeculectomy fistula also, and the chances of failure are much more than a routine POAG or PACG case. So first of all, I think that is a challenge, that even if you have done a very good surgery, and if you follow up the patient over a period of time, eventually in 2 to 3 years, the surgery is going to fail. And since the anterior chamber in most of these cases is very shallow, it's a challenge to put an AGV also, like implant also, although literature suggests that the prognosis for tube implants is better than trabeculectomy, but again, it's a challenging situation unless you put the tube through one of these holes, even in phakic patients, because the peephole approach of tube placement can be adopted. In this particular patient, since it's a angle closure types, the chances of malignant glaucoma, I think, are there in patients with angle closure glaucoma. The incidence is more because of the subclinical uveal effusion which can happen in these patients. So I also have one patient like this, and I think in such patients, if she had improved with atropine, I think lifelong you can put the patient on atropine. So you have to keep the iris lens diaphragm backwards by keeping the patient on atropine. I think cycloplegics lifelong.
That's the dilemma. That's the dilemma. We are also trying not to touch her because she's phakic 6/6. And of course, the pressures are fine, ranging between 12 to 16. And with atropine, she kind of settles down symptomatically also and vision-wise also.
So what is the
Rina,
harm in giving atropine?
Rightly said that atropine has to be given lifelong.
Yeah, it has to be given actually. Malignant glaucoma, if you don't want to intervene, and since the vision is 6/6, I think there's no point in intervening if it is getting corrected with atropine.
Like Sunita was saying, that things will go bad in time. And when they do, please be prepared that before the cornea becomes so bad that you can't do a good cataract extraction, you have to do a cataract surgery. And sometimes you may have to do a vitrectomy to do a posterior implant. Because I think in these kind of situations, now we have had number of cases in which people had done anterior tubes and they all got into trouble, and the cornea started getting into trouble. So before these things happen, you have to pre-perceive, and as long as the cornea is okay, immediately do a cataract so the chamber deepens off, and then you can do a vitrectomy and put a tube behind.
So even we had told the patient that you might actually need a combined cataract with vitrectomy because we wanted to break the hyaloid face and see if we can, stop this whole cycle of aqueous misdirection.
That's right.
But you also said that if you're on atropine, you tend to behave well, we'll follow you closely, then
Yeah.
maybe we can wait and watch. But the moment we feel either the cornea is getting decompensated or the pressures are going up, then we've also kept her on aqueous suppression with Diamox, but simply to reduce the amount of aqueous misdirecting. But we also prepared her that
we must congratulate Rita for a wonderful case presentation, and obviously for you all to.
So I think atropine is a good choice. I think you can keep the patient on atropine as long as the vision is
we don't want to do anything more.
I don't think there's no need to do any intervention. As such, I think specular count must be very low in this patient.
Yeah, she has also typical.
So,
but there's going to be a second wave and she's going to be missing for another 1 year. So
I hope not, sir. I hope not. Okay. Thank you, Dr. Rita. Thank you so much.
Thank you so much.
And thank you, sir, and Dr. Sunita for contributing in discussion. Dr. Anupama, can I request you? Dr. Anupama is a very senior ophthalmologist in Noida, and she's also a very multifaceted person. She does anterior segment retina, glaucoma, everything in her practice. So I request her to please present her case and we can all discuss it thereafter.
Yeah, I'll just share my screen. So this was a case which came to us. She was a 32-year-old. Am I audible?
Yes.
Yeah. So she was a 32-year-old female patient who came to us with sudden diminution of vision in the right eye. There was pain, redness, photophobia, and diminution of vision in the right eye. Left eye had mild visual loss. Past ocular history was not significant. There was no refractive error as such. And past medical history, the patient had some seasonal allergies. There was no history of migraine. Family history was also not significant. There was no history of glaucoma in the family. When we took the treatment history, patient was on topiramate 100 milligram twice daily for an epileptic disorder. On examination, the right eye vision was 5/60 and with pinhole it was 6/18. The left eye vision was 6/12 and with pinhole it was 6/9. Intraocular pressure on applanation was 36 millimeters of mercury in the right eye and 28 millimeters of mercury in the left eye. Ocular motility was normal in both the eyes. Pupils were 6 millimeters in the dark and 5 millimeters in the light, and there was no RAPD in both the eyes. External examination was normal in both eyes. On slit lamp examination, there was diffuse conjunctival congestion. There was mild corneal edema in both the eyes. Right eye showed flare 2+, CES 2+ in the anterior chamber. There was mild fibrinous reaction in the anterior chamber. Left eye also showed some flare. It was just 1+. The AC was shallow in both the eyes. And gonioscopy revealed angle closure in both the eyes. When we did the visual fields, they were normal in both eyes. So we did a posterior segment examination, and the posterior segment was not visible in the right eye because of the fibrinous reaction in the anterior chamber. However, it was visible in the left eye. The left eye fundoscopy showed mild vitritis, and B scan showed choroidal thickening in the right eye. So you can see the choroidal thickening here in the right eye. So a diagnosis of bilateral panuveitis, secondary angle closure, topiramate induced was made. The patient was asked to discontinue topiramate immediately. An AC tap was done and sent for gram stain, KOH stain. Culture and sensitivity was also done, which were negative. These unfortunately, we don't have the ASOCT, but the ASOCT in such cases shows narrow angles, and there is usually an anterior shifting of the lens iris diaphragm. The ciliary body may be swollen up and anteriorly rotated. So you can see the ciliary body rotation here. Laboratory investigations were done to rule out all the infectious and non-infectious causes of uveitis. CBC-ESR was done, Montoux chest X-ray was done. Serum ACE levels were done, RA factor was done, ANA, TPHA, HIV1 and HIV2 were done. All the investigations were within normal limits. So the treatment was started. Patient was started on systemic steroids and cycloplegics. Tablet omnacotil was started 60 milligram once daily. PAN 40 was given once daily. Prednisolone acetate eye drops were given 6 times a day. Homide eye drops were given thrice daily. And anti-glaucoma treatment was given in the form of Combigan, that is timolol plus brimonidine combination. And when the patient came 1 week later, she was much better with a visual acuity of 6.9 in the right eye and 6.6 in the left eye. IOP was within normal limits, and the AC was quiet. A repeat gonioscopy was done, which revealed open angles in both the eyes. So treatment of such cases is usually aqueous suppressants plus minus acetazolamide. Acetazolamide has to be used cautiously because it's a sulfamide drug and it might increase the side effects caused by topiramate. So you have to be judicious when you're using acetazolamide. In such cases, beta blockers and alpha-2 adrenergic agonists are the best combination. Prostaglandins have to be avoided because they might aggravate the inflammation. And usually the UV-scleral outflow is compromised in such cases, and prostaglandins may not help as they increase the UV-scleral outflow. Myotics are again contraindicated because they might increase the pupillary block and cause further anterior shifting of the lens iris diaphragm. Again, never go for a laser PI as pupillary block is not a component in this condition. The prognosis is usually good if the medication is stopped early and prompt treatment is started. Early treatment causes resolution of the ciliocoroidal effusions. There's improvement of visual acuity within 1 to 2 weeks, decrease in IOP, the AC reaction normalizes, and if not recognized early, a constant high IOP may lead to optic nerve damage. So topiramate is an anti-epileptic drug which is usually prescribed for epilepsy. And these days it's also being prescribed for migraine, depression, weight loss, neuropathic pain. The side effects are acute angle closure glaucoma, although the incidence is very less. And anterior uveitis, pan-uveitis, hypopyon may also be some of the side effects. The incidence of acute angle closure is 3 per 100,000 cases, which is very less, but yes, it is there. The symptoms usually start within 1 to 2 weeks of starting the treatment, and they should be recognized early. The drug is given in the dosage of 100 to 200 milligrams for epilepsy and 50 to 100 milligrams for migraine twice a day. It usually affects both the eyes if it causes side effects. There might be blurry vision, which is more for distance than for near because of the myopic shift which it causes. There's anterior movement of the lens iris diaphragm. There might be corneal edema, shallow AC, closed angles, mid-dilated pupil without iris bombe, and ciliocoroidal effusions. The ciliocoroidal effusions are the basic reason why angle closure happens. So if we look at the pathophysiology, there's accumulation of excessive fluid in the ciliary body and the choroid. This is because of increased permeability of the ciliocoroidal vasculature. There's edema of the choroid. This causes increased retrolenticular pressure and anterior shifting of the lens iris diaphragm. The ciliary body swelling might be there, and this causes anterior rotation of the ciliary processes and leads to angle closure. Then you see a myopic shift, and the inflammation which is there might cause uveitis. So the mainstay is stopping the treatment first and starting the treatment early. Thank you.
Thank you, Dr. Anupama. Dr. Harsh, Dr. Sunita, would you like to comment a little? Because this is not uncommon that we see bilateral angle closure attacks in patients on topiramates, mostly without inflammation, but sometimes with inflammation. And I think it's an entity which general ophthalmologists must recognize and not treated as primary angle closure with PI because there's no pupillary block here. And the treatment is actually contralateral to PI or pilocarpine, actually dilating these eyes, giving them cycloplegia. So Dr. Harsh, Dr. Sunita, would you like to comment?
Anupama, wonderful presentation. And all the time, actually, I was not seeing the case. I was wondering, what is your background? Is it Singapore or is it Vancouver or is it Noida?
I myself don't know. I just put it whatever was available on the Zoom.
Come on.
They have these preset backgrounds, no? So I usually keep changing the preset backgrounds.
Okay.
Yeah, but Harsh, Noida is becoming like Singapore now.
Yeah, so that's what I said. It may be that, but it looks like Singapore. Anyway, so wonderful presentation, and definitely what Reena was said was the right thing, because all of us are seeing such kind of patients in whom PI has been done, pilocarpine has been used, and things have become worse. And everything has been nicely said. I just wanted to say that instead of homide, sometimes atropine actually works better. So maybe we can start with that, and just everything else is very nicely done. and that is what is to be done. I just wanted to remind people that sometimes when things don't work, you can do an iridoplasty also to get the pressure down for time being, because it will take 3-4 days for the things to work out, and it really works well at times.
I would like to point out one thing. I'm in a multi-specialty hospital, and I keep on getting from neurologist neurology calls, and with this topiramide-induced glaucoma. What we need to do is to educate the neurologists also, because they put a lot of patients on topiramide. And I really thank Reena, because first of my patients I had sent to her, and she opened my eyes to this new entity. And I'm really thankful to her that now I'm able to diagnose and treat them, and tell the neurologists also that you should be very careful with topiramide. The moment they have red eyes and high pressure, you must stop the treatment.
So one thing I would like to add is that, can you hear me? Actually, I'm using iPhone for speaking. Can you hear me?
Doctor, there are two devices. Can you just click on just close one?
Okay.
Okay,
No,
so
I think.
yeah, we will hear you. Go ahead.
Yeah. No. The index of suspicion is when the patient presents with bilateral acute angle closure attack, because in patients with angle closure glaucoma, although they can present with bilateral, but it is pretty rare. So I think if patient presents with bilateral, then I think history is very, very important. And if you do ask history, patient can give the history of using topiramide. And the treatment, of course, as Dr. Harsh mentioned, is different. I think one has to use cycloplegics and steroids, and not the pilocarpine, and PI is not required. So I think we do get to see such patients, although rare, but they're still there.
All right. So thank you so much, Dr. Anupama, for a
Thank
lovely presentation and good discussion. Shall we, now it's 8:40, let's take the next case. So it's Dr. Prerna Mata now with us, who's a budding ophthalmologist, now already has established her practice in Noida and sees a lot of glaucoma and does a lot of glaucoma work. And I'm most happy to welcome Dr. Prerna. Please go ahead and present your case.
Yeah, thank you, Dr. Reena, and thank you, NOS, for inviting me for the presentation. So I will be talking about a very simple case, and discussion will follow. I hope I'm audible. Yeah. So I saw this patient last year, November 2020. So 65-year-old male patient. He was out of towner, and he came with a sudden onset of severe pain, redness, dimness of vision, watering, photophobia in the left eye. According to him, the symptoms were there for last week to 10 days, but he kind of ignored them. And when they become very, very severe, then he came to me. So in the medical history, was diabetic for 20 years on treatment, not very well controlled. Hypertensive for 25 years on treatment, hyperlipidemia. And there was a history of past penavitrectomy, which was done in the right eye due to tractional RD 3 years back. So after 6 months, he had a repeat episode, and again the surgery was done, and he lost his vision in the right eye. In the left eye, there was cataract, and the phacoemulsification was done at the same place in Kanpur 2 years back. And some, according to him, intravitreal injections were given 1 monthly apart, and 3 injections were given. And 6 months back only, he got YAG capsulotomy done. And then lockdown happened, and I think he could not visit the hospital again. So on examination, his right eye was PL negative, left eye finger counting close to face, conjunctiva was congested in the left eye, I'll be speaking about. Cornea was edematous, almost grade 3, could not see too much of iris details. Pupil mid-dilated, sluggish, reacting. Iris again had hazy view, obviously. So the lens was pseudophakic in the left eye. Fundus also had a hazy view, could not see much. Intraocular pressure NCT was around 50 in the left eye, and right eye was 12. Gonioscopy, right eye had open angles, left eye did not do gonioscopy in the first visit. And then patient was already using Alphagan Z eye drop from last 6 months when he last visited the hospital. And after that, he could not go for the follow-up visits. So immediately started him on mannitol, IOPAR SR, acetazolamide twice a day for 3 days. Then combination of timolol, brimonidine, brinzolamide, all the maximum medication was given. Loteprednol to reduce the inflammation, and cyclogel, to take care of the congestion and pain. So after 3 days of maximum medication, which I could give orally, then cornea became a little clear and I could see the left eye findings. Vision had come down to finger counting 2 meters after that. AC had mild flare. New vessels were seen on the iris surface along the pupillary margin. He had grade 3 NVI, so almost 2 to 3 quadrants were covered. NCT again came down to 20, between 20 to 25, it was fluctuating. PACI was 523, so it was not related to the corneal thickness. Gonioscopy could see new vessels along the trabecular meshwork along with the peripherantius synicum 3 quadrants. So again, grade 3 kind of NV according to the Wies and Gold classification. Fundus had neovascularization of the disc, again, maybe long-standing PTR, CD.6, temporal pallor, little bit of peripheral laser marks. Foveal reflex was dull and hemorrhages at the posterior pole was visible. I don't have too many images, so I've taken them. So ultrasound, A scan was done the right eye, which showed tractional RD. OCT of the macula was done. Left eye showed foveal distortion and cystic edema. So I came to a differential diagnosis of NVG, which was the most possible diagnosis in a case of a PDR. Acute angle closure and uveitis was ruled out. And uveitis, since there was no history of uveitis, and angle closure, since the other eye angle was open and the patient had never had this kind of a history before. And these are the images. I mean, this is how the neovascularization of iris looks like and the angle. So I've taken them out from the net. I did not have the recording at that time. And this was the image of the fundus, which again I've taken up. So the active neovascularization of the disc and the L-sphere neovascularization, this is what it looks like with the hard exudates and central macular edema. So diagnosis of neovascular glaucoma in the left eye was made, seeing the raised IOP, painful red eye, angle closed by new vessels, history of PDR, and history of using anti-glaucoma medication. Maybe if he was on regular follow-up, this NVI could have been picked up earlier and the treatment could have been started. So the first thing that we did, in association with the retina surgeon, did a PRP, 12 to 1600 burns, 500 micrometer apart, one spot size. And on 1 to 3 settings over 3 to 7 days, the PRP was finished. And patient was on the 10th day given intravitreal anti-VEGF injection of 0.05 ml of ranibizumab on day 10. So this was just to take care of the ischemia and the hypoxia. So treating basically NVG with the medical therapies like arranging the deck chairs on the Titanic, which you can never get the right amount of pressures. So finally, waited for the neovascularization to regress 2 to 4 weeks, and the vision came back to finger counting 3 to 4 meters. IOP was 25 millimeter of mercury after the maximum medication, still on Diamox. So now the contemplation is that surgery has to be taken, done ASAP, because insufficient IOP control despite maximum medication, extensive PAS, and which includes the angle, impedes aqueous outflow. So the choice is between trap with MMC and glaucoma drainage device. So these are the two options which we have. So basically, now a little bit of discussion on NVG. I also, wrote on that. Controlling the ischemia and halting the production of angiogenic factors, finding alternative outflow channels, decreasing the aqueous production to control the IOP, and controlling the painful blind eye. So this is what we need to achieve. As we all know, what is the pathogenesis of NVG? So there's a chronic retinal ischemia, angiogenic factors are released, and neovascularization iris and angle takes place, and that leads to neovascular glaucoma. So the basic thing is catching it at the right time and starting the treatment at the right time, because there is no clear-cut, end stage for this disease. So some causes of NVG, which this patient had, was PDR definitely, and CRV also causes, like 33% of PDR patients go in for NVG, 33% of CRVO patients, and rest of the cases also RD, uveitis, eels, traumas, tumors, ocular ischemic syndrome, carotid cavernous fistula. So, and stages of NVG, like maybe that patient when presented 6 months back was on a pre-rubiotic stage, so that's why the rubiosis was not picked up and was not informed that you need to come for a regular follow-up. So, and then when he came after 6 months, I think the lockdown had a lot of effect on follow-ups for a lot of patients. So he had already developed rubiosis, and now he was on the 4th stage of secondary angle closure glaucoma. So like discussed before, so management is same. When if we see a patient early, we go for PRP and medical therapy. If we see them in advanced stage, we go for the surgery. And the end stage, just to save the eye and the painful blind eye, we go for cyclodestructive procedures. So I think that's take-home message for any case of NVGs. Early intervention in the case of NVG can save the vision, and IOP control must be a long-term rehabilitation. So early surgery, early rehabilitation. So glaucoma drainage devices are sometimes better than TRAB in NVG cases because the conjunctiva is not scarred and all that. So thank you very much. I thought I'll make it quick.
Thank you so much, Dr. Prerna. That was a very good presentation. And I think neovascular glaucoma is a disease that we often see in our clinics. And it's very important to diagnose it in time and treat it appropriately to salvage the vision in eyes where we can. And Dr. Sunita does a lot of AGVs also. So I'd like to ask her a question. Maybe you can discuss, Dr. Sunita, tube versus trab. What are the situations where you would consider a trabeculectomy with mitomycin C after having given anti-VEGFs and PRPs? And what is the sweet spot? How long do you like to wait after giving the anti-VEGF if you're planning to intervene surgically? And when do you choose a trab and when do you choose a tube?
Yeah, so I think management, as you rightly said, management of neovascular glaucoma is very challenging, and you have to keep 4 principles in mind. One is reduction of NBI, like neovascularization, reduction of neovascular drive by giving, either Avastin, anti-VEGFs or doing PRP. And third is reduction of inflammation, and fourth is reduction of intraocular pressure. So I think all these things which are happening simultaneously have to be dealt with together, because we may not be lucky to have a very early open angle stage wherein just there is some new vessels on the iris or in the angle, and such cases respond very well to the medical therapy. So you just prescribe you just prescribe steroids, cycloplegics and anti-glaucoma. They do well, and then you can go ahead with your PRP and other things. The challenge happens when it's a chronic angle closure stage, wherein the fibrous proliferation has closed the entire angle. There's extensive neovascularization, and the pressures are very high, and media is not very clear. So retina surgeons may not like to do PRP at this stage. So they refer the patient to us that first manage the intraocular pressure, and then we will go ahead and do PRP or whatever. So in that scenario, giving anti-inflammatory and then anti-glaucoma drops, what I do is that I do a graded TSCPC to reduce the pressure. As a temporary procedure, you can just reduce the pressure with TSCPC. You should not do it 360 degree, but maybe 180 degree. So just to temporarily reduce the IOP. And once the IOP is reduced, you can give injection Avastin, and you can then go ahead with your either glaucoma surgery or combined surgery if cataract is also there. Or if there's no cataract and the media clears, then PRP can be done. So I think the challenging situation is when you are dealing with a very advanced stage with media, hazy media, and along with cataract. So as far as tube and trab is concerned, like if you're combining it with phaco, then I would like to prefer tube, because again, if it is because of the diabetes, it's a progressive condition, and progressive inflammation is going to be there, and trab may fail eventually. So, but if it's a phakic patient and you have nicely controlled the neovascularization, and if the lens is clear, then you can go ahead and do a trab also. So the success of trab is also good. And like I recently heard Dr. Pencaw talking about use of Avastin in every trabeculectomy. And the logic is that especially the inflammatory glaucomas, there's a lot of VEGF release, which causes vasodilatation. So you have to give, when you give anti-VEGF along with trab, you are going to reduce that vasodilatation and inflammation and preventing failure of trab. So he gives an intracameral Avastin in every trab of uveitis and neovascular glaucoma. So you can improve the success of trab by taking due precautions, reducing inflammation, giving Avastin, and there's no harm in giving Avastin during surgery also. In the anterior chamber, you just reduce, you just give injection of Avastin, and it will be there for a couple of days. taking care of inflammation. So I think that is a regime which I follow.
So it's interesting that you mentioned anti-VEGF in every uveitis patient. Also, if you're doing trabeculectomy, I didn't know about that. The other challenge I feel is when you've created a filter in the eye and you've done a trabeculectomy, even if you inject something in the anterior chamber, it actually gets filtered into the trabeculectomy site. It doesn't really remain in the anterior chamber. But I still feel you're right. Some amount of anti-inflammatory VEGF release can be.
But it is going to be there for a few days. Initial, if it remains for 3-4 days, also it is going to reduce the inflammation. So that is what I have not been using in all cases, but I recently heard in one of the webinars he telling this. So I'm just sharing his views, and I found it quite logical to use Avastin in inflammatory glaucomas at least.
Sunita, it's very interesting that when we use Avastin for retinal disorders, it's medically said that Avastin for the retinal disorders will actually increase inflammation in the vitreoretina. So it's a little paradoxical that why, but
so
I think
vasodilatation, but it causes VEGF causes vasodilatation, which increases the inflammatory exudation. That is what is the logic. So I don't know, but
we have been using. We wrote this publication in 2008 in ophthalmology. That one of the first publications which told that in high myopes where you don't want to use mitomycin and you are not good at Ologen, which many people are not good at using, then you can use Avastin in the bleb itself. And I have been regularly doing for all high myopes with wonderful results.
So I know this article with Dr. Grewal that you published, right?
Right.
I will use. I somehow also initially was wanting to understand that I used it, but maybe I didn't choose the myopes. And my results with anti-VEGF subconjunctival were very mixed, especially if it was high, late stage disease. But myopes I've not tried. Maybe there is some.
So I'm using only in high myopes where MMC can't be used, and I'm not very good at using Ologen.
So I use a lot of Ologen in high myopes. In fact, I use only Ologen in high myopes.
Fair enough.
Yeah, that is pretty clear that in high myopes one should use MMC very judiciously because it can cause a lot of complications, hypotony and all.
Right. So I think thank you so much. I think we have another 5-10 minutes to quickly finish the program. I request Dr. Ajay Arora and his better half, Dr. Ritu Arora, to present the last case. I think Dr. Ajay Arora and Dr. Ritu Arora do not need any introduction. They have been almost now, I think, legendary ophthalmologists of Noida. They've been there so long, and now they've opened up their big practice of Vision Plus Eye Center, which is doing extremely well. So I think Dr. Ajay Arora would like to present the case. So all to you, Dr. Ajay.
Yeah, I'll just share my screen. It's very, if I make mistakes, please pardon me because I'm basically a retina surgeon. So can you see my screen?
Yeah.
Okay, so I think this presentation might actually answer some of the questions which were raised by Prerna. This is basically on treatment with the micropulse laser cyclophotocoagulation. So this was a 62 years old male, hypertensive, non-diabetic with a family history of glaucoma who presented to us in June 2020 with blurred vision and pain in the left eye. Patient had earlier undergone phacotrab elsewhere in February 2020 and later was diagnosed with CRVO and a simple retinal arterial obstruction. In the right eye, patient had earlier had cataract surgery with pseudoexfoliation, PCIOL, visual acuity was 6/9, intraocular pressure was 14 millimeters of mercury. The fundus in the right eye had a large cup disc ratio with a compensated BRVO with ERM. Now coming to the left eye, the patient had a visual acuity of hand movements close to face, an RAPD when he presented with corneal edema, a flat congested bleb with pseudoexfoliation, and IOP in the left eye was about 42 millimeters of mercury. So the media was hazy, the disc was pale, and the cup disc was 0.9 with 4 quadrant retinal hemorrhages and macular edema. So 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 4 quadrant retinal hemorrhages and We went ahead and did a gonioscopy, anterior segment photograph, fundus photo, OCT, ONS, macula, octa, and the fields for the right eye. So this is the picture. It was a congested lip. This is after the pressure had come down. The cornea had become better. So this is what the patient looked like. So the plan was to give a maximal anti-glaucoma therapy. And we had an option of repeating a trap with MMC, the question which Prerna just asked, or go ahead with a glaucoma valve. We did the OCT of the optic nerve head, and we did an octa, which was looking at the deep capillary plexus, which it was very obvious that there was a large perfusion defect, which typically occurs with the venous occlusions in this patient. So the patient, after having control with the maximal anti-glaucoma therapy, underwent a trap with MMC in June of 2020, which is a few days after the patient presented to us. And post-op, the patient did well for 2 months. The intraocular pressure was 10 millimeters of mercury without anti-glaucoma therapy, but again, the bleb started getting congested with dilated tortuous vessels. In 26th August, it appeared like a failing bleb. The intraocular pressure had gone up from 10 to 18, and the patient was started on Travacom. 2 days later, that is on 28th of August, patient presented with a pressure of 60 millimeters of mercury with corneal edema. At this stage, Dr. Ritu went ahead and did a bleb needling with an injection of 5-FU and was put on maximal anti-glaucoma therapy. So at this stage, you can see that repeat gonioscopy. You can see here, you can see the vessels in the angle. You can see a heme in the angle again on a gonioscopy. So patient was given an intravitreal injection of Avastin, followed by peripheral laser barrage in 2 sittings. The IOP did come down to 32 millimeters of mercury on maximum anti-glaucoma therapy. This is October. But the pressure was not coming down, and the patient had already undergone trap twice. So we had an option of doing a glaucoma valve versus a micropulse laser cyclophotocoagulation. At that point, we had procured the micropulse, and we decided that let's use it. So the patient underwent a subcyclo for cyclophotocoagulation on 6th of November, where basically we are treating both the superior and inferior half. We decided not to treat the trap area. So here we use 2-watt application of 31.3% duty cycle. Basically, you treat 90 degrees for 90 seconds, 180 degrees. Now, I find it practically difficult to treat the entire 180 degree at one go in a sweeping motion. So I actually divided it into 2 quadrants. One quadrant may be a little bigger than the other. For that, we give 50 seconds. And the other quadrant is a little smaller. We make it 40 seconds. So a total of 90 seconds. And similarly, if you have to treat both halves, again, 180 seconds. You end up treating about 320 to 330 degrees. And this is with a probe which is kept 3 millimeters. This is the probe. It's got a glass-like cylinder in the end, which helps in the sweeping motion. And this is kept 3 millimeters from the limbus perpendicular to the scleral surface with a coupling agent, and always a peribulbar block is given. This is a small little video which will show you. So we are trying to identify the ciliary body. And I'll cut off the music. So the horizontal margins, the 3 and 9 o'clock positions are marked. I marked the quadrants in which we are going to do it. And we first create a track at 3 millimeter, just create a path on which we can move. Then the thing is activated, and we can do it for about 50 seconds. So now the laser has been activated, and you can see the laser is being given. So when the laser is activated, the light is constant. When it is not activated, it is partially. And at the end of, so we treated both the quadrants. At the end of it, you give a steroid injection. So this is always done in the operation theater with a block. The probe is kept perpendicular. The probe features a glass ball at the tip of the needle, ensuring an easy and comfortable sweeping motion. Patient is put on topical steroids for a week and with NSAIDs for about a month. And topical anti-glaucoma drugs are continued, and they can be stopped as the time goes by. So once the patient was treated, the next day's patient's pressure was 7 millimeters of mercury, which was quite remarkable for us. I'd never seen something happening like that. The eye was quiet, patient was pain-free. The anti-glaucoma drugs were restricted to daughters. In December, the pressure went up to 10. In January, it went up to 12. In February, it went up to 24. So in March 2021, that's almost over 5 months later on, we could again see NVI with a minimally dispersed vitrocine. And this is the picture on 5th of March. You can see macular edema, which was spongy and cystoid in nature. So at this stage, I went ahead and gave an intravitreal injection of Avastin, did an augmentation of laser under peribulbar block, and interestingly, the patient had come to me today where the macular edema had totally subsided. We did an OCT and we found that macular edema had seen, but I couldn't get the pictures for you today. So the macular edema subsided, and we are now planning to repeat micropulse because this is a repeatable procedure. Just a small little word, I think Sunita has already discussed. We have two procedures. One is PCP, which is pretty old, which is basically based on a thermal, it's an 810 nanometers laser. The beam is transmitted through the sclera, absorbed by the melanin and the ciliary processes, which leads to the coagulation of the ciliary body tissue. So the cycler destruction can be caused in the pars placata area or the pars plana area. When you cause the destruction in the pars placata area, it will cause reduction of the aqueous production. When you cause more destruction in the pars plana area, it will actually cause an increase in the uveoscleral outflow. So generally at 3 millimeters, both get targeted to an extent. And micropulse laser people, so this is the retina slide. When people say what micropulse is going to do, and when it was thought with the anti-VEGF agents, they thought that the laser is dead. Micropulse came in just like when Mark Twain was declared dead. He said reports of my death are greatly exaggerated, which basically shows that micropulse laser has come back. And this is again a retina slide just to show you this is a continuous wave laser. If you chop it into multiple beams with a time in between where no laser is active, that is micropulse, and this is called a duty cycle. In the retina, we use a 5% or a 10% duty cycle, but in glaucoma, a 31.3% duty cycle is used. So if it is a full cyclodestructive procedure, a 100% duty cycle. If it is a micropulse, it's a 31.3% duty cycle. So you can choose between a cycle of 31 to 25% duty cycle, and accordingly, for a treatment of 180 seconds, which means 90 seconds above and 90 seconds below, you can divide it, and you can further divide it for each quadrant, and that becomes micropulse. So how does it work? It causes a selective destruction of the pigmented ciliary body with a minimal coagulative necrosis of the ciliary body, which reduces the aqueous humor production. And then it increases the uveoscleral modeling, increasing the uveoscleral outflow. It may also act on the longitudinal fibers of the ciliary muscle, causing a displacement of the scleral spur, which in turn modifies the configuration of the trabecular meshwork. And all this also increases the filtration. So the take-home message is we have the drugs and we have surgery, but there is a zone in between that needs to be filled up. And this zone should be that whatever comes up in between should be that it improves the compliance, makes the procedure efficient, and has reproducible result, leaving future options open. So that possibly may have a role to do with a subthreshold laser, But yes, it is yet to be seen. Subthreshold laser may work as an interim measure before the definitive procedure like a glaucoma valve or something else is taken up. Like what Sunita said, that the retina surgeons want the pressure to be controlled. You could probably do a micropulse laser, bring the pressure down. When pan-retinal photocoagulation can be done, anti-VEGF given, and then you can go ahead with the glaucoma valve. Thank you for your attention.
Thank you, Dr. Ajay. That was a very interesting case presentation, and you covered the micropulse laser in detail, giving everybody enough knowledge to understand how it works. And I think that's another new kid on the block, which many people are using.
I can't hear you, sorry.
Sorry. I said that's a new kid on the block. Am I audible now?
Yeah.
So that's a new kid on the block that many people are even using to treat primary glaucomas. I don't have personal experience because I don't have access to the machine. Only thing I would like to say is that few patients that I've seen who had micropulse laser in primary glaucomas, the effect is usually short-lived. And I also feel too early to say, but some of the patients whom I've had to operate with trabeculectomy, I felt that the conjunctiva didn't behave quite the same as in a virgin eye without micropulse laser. So these are small things that we need to remember. But I think we all need as many possible options available in glaucoma armamentarium, and there are situations where we are helpless and we need to, as he said, there is a gap between what is available surgically and medically. So micropulse laser is gaining attention. Dr. Harsh and Dr. Sunita, would you like to comment if you're using your glaucoma practice?
I think I'll agree with whatever Reena has said precisely. Ditto. You have to, you can use it, but I have been operating a whole lot of patients who have already undergone micropulse. So if the result is there to begin with, you are lucky. It can be long lasting, but it could be very short lasting too. So you definitely can use it. There's no harm at all. And but be just careful, especially not in one-eyed patients, because there may be some side effects that we have seen from other places.
I also have a comment to make here.
Yeah.
Yeah, so I have also used in some patients, although we don't have the machine. But as any other laser, if you underdo it, you have to repeat it. If you overdo it, you can land up into complications like hypotony and all. So that's true with laser also. And I have seen some of the patients where the micropulse has been done, and then after that, if a trabeculectomy or tube implant has been done, then sometimes there is hypotony, because sometimes it causes de-optimization of the ciliary body. So ciliary body is not in a very optimal stage after undergoing such lasers. So there are instances wherein when you start anti-glaucoma, it will go into hypotony. When you withdraw anti-glaucoma, the pressure will rise. So I have seen 2-3 such patients in whom the IOP kept fluctuating on withdrawing the drops and all. So the reason which I found out is that the ciliary body is not in optimal condition. So one has to, as Dr. Arora said, that we have to optimize and titrate our settings as to how much is required in primary glaucoma and secondary glaucomas, because
exactly. I think that's the point with cycloablative or cyclodestructive procedures, because I've had the opportunity to play around with HIFU also, which is basically an ultrasound, but it's also ablating the ciliary process with the same objective, and also the ECP, the endothelial coagulation. But in all these procedures, basically, I think one has to remember that not only are you tampering with the normal physiology of the ciliary processes, but also I feel the subconjunctival area sometimes gets a little change. So when you're doing a trabeculectomy, to me, the success of trabeculectomy also gets compromised to some extent after these laser procedures. That I think we have to keep in mind when we offer these procedures to patients, but too early. Maybe it's a game changer. Maybe
but we do need such lasers also, I think, in at least 10-15% of our practice. We are not able to do any other surgery and stage. But we will not recommend it as a primary procedure in primary glaucomas, I think, which people have started doing, I think, in India.
So I think, Dr. Ajay, in the interest of time, it's already 9:15. So I'd like to thank all the speakers, Dr. Harsh, Dr. Sunita, especially taking out time for this meeting. And I'll give it on to Dr. Goel and Dr. Ajay to thank everyone and close the meeting. And all the presenters who presented very good cases. And thanks, Dr. Harsh and Sunita, for making a nice discussion. So over to you, Dr. Ajay and Dr. Goel, to please conclude the meeting. And Dr.
Thank you, Dr. Reena. All the cases, they were very nicely presented, and each case had a message to convey. And I was also very much surprised that the cases were very interesting, and we never thought that the topiramate like drug that can cause bilateral glaucoma. And of course, it is written in the literature, but we have never come across such case. And similarly, Dr. Annapurna and Dr. Prerna also presented the cases very well, and Dr. Ajay Arora has highlighted the role of micropulse laser in glaucoma as well. And Dr. Harsh and Dr. Sunita Dubey, they have given nice expert comments, and which were really conveying the message. So now I request Dr. Ajay Arora to close the meeting and thank our experts and other speakers. Dr. Ajay.
You're muted.
Dr. Ajay.
Please unmute yourself, Dr. Ajay.
He's very hungry. He can't speak anymore.
No, the thing is, when you were talking about micropulse, your comments I couldn't hear because there's something went wrong with my speaker. So I don't know. I'll hear it later. But basically, it's still an experimental thing, and it's still a device which is but it is giving very good results to us. And I think it's an interim device. We are yet to see what are the long-term effects, but from whatever the world literature is showing up, that the effect may last for about a year or so. And there are a lot of good studies available from various places, and they have shown that it is effective. We will put up our cases together. We have about 6 cases now, which are all cases which are advanced cases where nothing much can be done, and we've been using them. And let's hope that we are able to show you in some subsequent meeting how it works. I would thank Dr. Harsh, Dr. Sunita, Dr. Reena, Dr. Anupma, Dr. Rita, Dr. Aarti, and Dr. Prerna for participating and presenting in this meeting. And thanks to Dr. Atul and Dr. Goel, who are always there to support me in this venture. At Noida Ophthalmic Society, we are trying very hard to make the atmosphere academically vibrant in Noida Ophthalmic Society, and I would like all the members of NOS to participate in these meetings, because we definitely have to go up there with NOS and make it really good. I would also like to thank Elergen for supporting this symposium. And thank you all, and have a very good night, and thanks a lot. Thank you, Reena, for sparing time because you had something emergency going on at home. But thanks for being here.
Thank you.
Thank you.
And of course, let me thank Dr. Ritu for allowing me to present the case. Actually, she is the glaucoma surgeon, because I am doing micropulse, so she allowed me to go ahead and present.
Thank you,
Okay,
everyone.
Thank you, everyone.